leaders in the country. Definitely Dr. Zohair Al-Halees from King Faisal and Dr. Ahmed Al-Umrani, who is representing the Adult Congenital Working Group from National Guard Hospital, which is again one of the leader in providing congenital heart disease surgery. So again, thank you for the Congenital Heart Disease Academy making this happen. Thank you for the board member of Saudi Heart with the leader of Dr. Walid Al-Habib, and also the management, Cons Ritaj by Engineer Ahmed Imam, making this possible. Back to you, Prof. Sasha. Thank you.
Good morning, everyone. Sasha, you ready for me to proceed? Did you have anything you wanted to show, or shall we proceed?
We can proceed. We can proceed.
Okay. Good morning, good afternoon, good night, wherever it is, whatever it is where you are. My name is Gil Warnofsky. I'm a professor of pediatric cardiology and cardiac intensive care, and one of the co-founders of the Congenital Heart Academy. I think when Grace and Sasha and I started to talk about this, we had absolutely no idea what the untapped interest and need was for these types of meetings. It's been truly inspirational to see how we can make some good out of a terrible pandemic. And the fact that we have a very diverse and international panel today speaks to that. I'd like to introduce our first speaker, Dr. Pranava Sinha, who's my colleague here at Children's National in Washington, D.C. He's an associate professor at the George Washington University School of Medicine and Health Sciences, and the director of our heart transplant program, and a dear friend and a fantastic surgeon. And he will be giving our keynote lecture, the first of two excellent surgical lectures today. And he will be talking about Tetralogy of Fallot then and now. And I'll turn this over to you, Dr. Sinha. Thank you.
Thank you, Gil. All right, can everyone see my screen? All right, thank you to the Congenital Heart Academy and the Saudi Heart Association for this opportunity. This is a very difficult topic, and it can be pretty simple to a pretty challenging job. So I'm gonna try to do my best to do justice to this entire span of managing tetralogy from then to now. I don't have any disclosures. Tetralogy is one of the earliest lesions to actually be described in a lot of detail. And it's also one of the first lesions to either be palliated surgically or so-called, get the so-called corrective repair. Despite that, it's still the most debated and controversial lesion. And if you put 100 surgeons in a room, half of them will agree that this statement applies to the other half for sure. Over the years, the initial approach of doing a palliative procedure, or that is a shunt followed by repair, has slowly been going down, and early primary repair is gaining more popularity. And that's primarily because of the pioneering work of Aldo Castaneda and Dr. Jonas, who's still one of the strongest proponents of early primary repair. In 2010, and this is one of the only relevant STS-based publications that is out there, about 10% of patients were being shunted. The other 90% were getting repaired. And surprisingly, the valve sparing operation was only done in 50% of patients. As the envelope for early primary repair was being pushed further and further, there were reports on either side, some claiming that it's actually fine to keep doing earlier and earlier primary repair, while others raising the concern that there could be increased not just mortality and morbidity, but also cost and other implications of doing early primary repair at a very early age. This was around 2010 to 2015, and this is one of the papers that came out at that time. This was based out of the FIS data. FIS, as we all know, is a database that it constitutes. Back then, it was 42 hospitals, so that number is up to 52 hospitals, which contribute data to an administrative database in North America. And even though it is an administrative database, using ICD codes, there's a lot of outcomes-based research that can be done using FIS. Whenever we look at hospital resource utilization or cost, the prices have to be accordingly adjusted according to geography and the time of the year. So in this database, in this study, the researchers looked at Tetralogy of Fallot all the way from neonates to 18 years of age, which by itself is probably the biggest flaw of the study. But it was noted that every possible outcome indicator for Tetralogy of Fallot was worse in younger patients. And that included time spent in the ICU, in the hospital, and on the ventilator. So the big question at that time was, does younger age and smaller patient size really lead to increased mortality and morbidity with early primary repair? And that's when me and our group here got interested in looking at this in a more systematic way. As we are one of the early primary repair centers, so we looked at our own experience over a 7-year period, and our goal was to look at outcome indicators and see if age and size of the patient does affect that independently. Because mortality is pretty low, our primary endpoints were more of morbidity and cost indicators. So we had 164 patients. Out of that, 155 were pure early primary repair group patients that had not received prior palliation. And the groups were pretty comparable when you looked at them stratified by shunt versus no shunt. And as far as the outcomes were concerned, but to get to the crux of the data, when we did a multivariable regression analysis to look at independent variables associated with increased morbidity and resource utilization, neither age nor weight at surgery were predictors of higher morbidity or cost. There was only one death in the series, so mortality was not, we didn't have the power or sensitivity to look at mortality. So prematurity, low birth weight, non-cardiac anomalies, and if the patient needed an urgent operations were the primary predictors of morbidity and cost rather than age and size. Of these potentially modifiable factors is only this, and I'll elaborate on that further because we have no way to change the other 3 factors. When we looked at the elective versus non-elective patients, they were pretty matched as far as age and size and other risk factors. But again, if you needed an urgent operation, you did worse at pretty much every point. The additional cost burden was doubling of cost if you're premature or needed an urgent surgery, and if you had extracardiac anomalies, and these were only major anomalies that we considered, was almost higher than 200% increase in the cost and hospital resources. So based on that data, we can probably answer this question that predictors of morbidity and increased resource utilization are not younger age and smaller size, but other factors that probably should be considered when we're making decisions about early primary repair. The other argument that's often kind of made is that early primary repair in the younger and smaller, more delicate patients could lead to more residual lesions and is probably technically a more difficult thing to do. We can't measure a surgeon's subjective feeling of how difficult an operation is, but we certainly can measure the technical performance of the residual lesions, and this has been proposed by Mina Nathan and the Boston group and Columbia group, that is Emil Basha, and is a well-validated method. So we went back and looked at a much larger cohort of early primary repair patients with the goal of identifying predictors of inadequate TPS with special emphasis on age and weight. As was shown by the Boston group earlier, our data was similar in the sense that if you had a higher technical performance score, which is inadequate technical operation, you did worse. That was not a surprise. What was a surprise was that age and size did not affect the technical performance scores. Neither did the urgency of the operation. So you could do an adequate or a good operation with low residual lesions in an urgent situation in a smaller and younger patient. What really played a big part in our series was any branch pulmonary artery issues, which led to inadequate TPS. Based on that, we concluded that technical performance or the residual lesions are not increased in a younger patient or a smaller patient. So if mortality, morbidity, and technical complexity are not affected by age, how do we know when is it too early to perform elective early primary repair? As in, what is the optimal age? And so we had to look beyond the usual endpoints, and we looked at the reintervention rate in our series. And this is a smaller cohort of patients where we excluded patients who had prior intervention, prior palliations, and patients with discontinuous PAs, because that was one of the very big influencers of inadequate TPS. As has been shown before, it is kind of obvious that the higher the gradient that you leave the operating room with, the more likely you are to need reintervention. But looking at the individual factors that could affect your need for reintervention, what we found that the size of the patient does not affect your need for reintervention. Now, this study had a follow-up, a median of about 2.5 years, and the interquartile range was about 1 to 5 years. So this is still intermediate-term follow-up and not long-term follow-up. As expected, again, technical performance score did influence your need for reintervention. What we really found interesting was that age, a younger age, increased your need for reintervention. Now, this study, again, because this was an intermediate-term study, valve-sparing repairs or a transannular patch was protective, but we all know that when we follow these patients for a longer period of time, they are going to need reintervention for PR. Now, when we did this analysis, we did not just arbitrarily choose a 55-day cutoff. We used age as a continuous variable, and using the ROC type analysis, found the inflection point for higher reintervention at 55 days of age. This is similar to data that later came out of Boston from Ram Imani's group, where they came to this cutoff of around 84 days of age. So around about 2 to 3 months of age is when your reintervention rate curve kind of flattens out. It makes a lot more sense when we look at this data from our previous series on the hospital resource utilization that we did. When you plot the ages of the patients as expected, you expect to see a bell curve, which is shown here on the left. It's a little bit skewed to the left, yes. But when we tease it out by elective versus non-elective, what is striking is that the need for non-elective operation is pretty high early on, and then the curve goes down and then starts rising again. So these are probably the patients with a much more severe form of disease, but I think that this later upstroke is because of the secondary hypertrophy that we see developing with time. And it comes pretty much to 2 to 3 months of age when you can actually prevent almost 50% of patients from having a cyanotic spell if you fix them at 2 to 3 months of age. So based on that data, it makes sense to do early primary repair electively at 2 to 3 months of age, as you're getting the best of both worlds. You are reducing the need for urgent operations, and you are also able to achieve a low intermediate reintervention rate. So what is the role of palliative procedures in patients who are less than the optimal age for early primary repair? What should we do? Should we still go ahead and repair them, or should we shunt them? And to answer this question, we went back to the FIS database, and we chose the cutoff at 3 months, and that was primarily because of the data that I just showed you, where 2 to 3 months is considered to be the ideal time. 3 months or older is less controversial as far as proceeding with early primary repair is concerned. But most importantly, FIS has limitations in identifying patients who have had prior palliation. In 3 months, it is very unlikely that patients would have had a shunt and come for their subsequent repair. So it made sense from that point as well. We looked at a lot of pre-op and outcome variables, but the method primarily was comparing patients who had primary repair with those who had shunts. What is notable is this data that reflects our bias to do shunts in younger patients and those who have more risk factors. Despite that, the outcomes, except for a longer ICU length of stay in the repaired group, was pretty comparable, but that was not enough. We had to correct for these differences in the cohorts. And so we went ahead and did a propensity matching where we matched the two groups for those risk factors and came up with eventually 248 patients in each group, so shunt versus repair. And as you can see now, the groups are evenly matched. And we found, again, that the ICU length of stay was slightly longer in the repair group, but pretty much every outcome indicator is comparable. So the argument that, that you could actually reduce your mortality or your morbidity by doing a shunt in a patient who's younger does not stand. What does affect your morbidity and mortality is the age of patient. If you have non-cardiac congenital anomalies and prematurity, irrespective of the approach, so you're going to have high risk no matter what you do, whether you choose to shunt or to repair in this class of patients. You're not better off doing one versus the other as far as mortality and early morbidity is concerned. So again, which means that the decision whether you choose to shunt or to do early primary repair should not be based on age and size alone, but on other factors. And the last question that we wanted to answer was, are there predictors of successful valve-sparing repair? Data that we looked at earlier when we were looking at our reintervention rate, the one thing that intrigued me was that every patient that required surgical reintervention at the level of the valve had interventions on their branch pulmonary arteries and distal PAs. And so the way we started approaching it is how you approach left-sided obstruction in Shones. I think that the only indicator that we broadly follow is pulmonary valve Z-score, but I think that we should look at the RVOT in a more comprehensive manner. Ramani at that same time had shown that the morphology of the valve is, in addition to the size, is an indicator. But what we did is we went ahead and looked at the RVOT, the entire right ventral outflow tract, in a more comprehensive way. And everything that was significantly different in the patients that had successful valve sparing versus patients who had either a transannular patch or a subsequent failure of valve sparing repair, so did not have their valve in place. And we put that into a model where we found that in addition to the pulmonary valve Z-score, it was also the main pulmonary artery Z-score and the urgency of the operation that predicted whether a valve sparing repair is going to work or not. And the inflection point, again, derived statistically, was a Z-score of -3 here and a -3.25. This was, of course, a binary variable. Based on this predictive model, we developed a scoring system where you could predict whether you're likely to succeed with a valve sparing repair or not in the intermediate term. So the successful predictors of valve sparing repair are more than just pulmonary valve Z-score. I think we need to look at the RVOT and the urgency of the operation in that equation. There are still many unanswered questions. And I think that the jury is out there whether the cumulative morbidity, mortality, and resource utilization of two-stage strategy is lower or higher than the early primary repair. The success of valve sparing repair, again, needs to be teased out in longer term reintervention studies. In addition to everything else, I think the neurodevelopmental outcomes of the two strategies and the other organ systems in terms of two anesthesias, two procedures versus a single anesthesia and a bypass run early in life have not really been teased out adequately. So with that knowledge, I hope that we can select our patients for early primary repair better. And as we learn more and more, there's still a lot of room for improvement. Thank you. I'll be happy to take any questions.
I think what we'll do, Pranav, is we'll ask people to put questions, and this is a good idea to remind our audience, which is incredibly now over 2,000 attendees. Thank you all for joining us. I would remind the audience to please put your questions in the Q&A box, not the chat. If you put that in the Q&A box, the speakers will answer them after their talk, as well as the rest of the panelists. And Dr. Sinha, if I could just mention one other thing that I think is really important from a cardiologist perspective, is that one of the most stressful thing I've seen in the families of babies with Tetralogy of Fallot is the fear of spells and the uncertainty of surgery. So what I think is very important, and your data supports this tremendously, is as soon as the diagnosis is made, pick an operative date between 2 and 3 months later. So the family knows when the surgery is going to be, can bring family to take care of their other children, et cetera. And then you could always move the surgery up. But sort of the anticipation of when's this going to happen, when is this going to happen, can be made better with that. So if we make a prenatal diagnosis, it's not uncommon to say, okay, your due date is today, say, and that we would recommend surgery will be at the end of October. And I found the families like that much more than the unknown. when to do the operation. And I think your data is very supportive of that. Thank you. I'm going to turn the, I don't know if you call it a microphone or the unmute button, but I'm going to turn the button over to Dr. Najashi to introduce our next speaker.
Yeah, so it's again a great pleasure and honor to introduce Dr. Zohair Al-Halees, who really might not need an introduction. He's a senior consultant cardiac surgeon in King Faisal Specialist Hospital and Research Center. He's an editorial board of many peer-reviewed journal. He had been designated to cardiac surgery, and he had received multiple awards in the region. King Abdulaziz Award Medal and Sheikh Mohammed Hamdan and bin Rashid from UAE as an Arab World leaders. He is the vice president and founder member of Governing Council of the World Society of Pediatric and Congenital Heart Surgery. He's always an addition to all our congenital heart disease service in Saudi Arabia. We are really very pleasure to have him here. Thank you, Dr. Zohair.
Thank you, Khalid. Can you see my screen?
Yes.
Great. Yeah. Thank you very much for everybody. Welcome for all our listeners. And I thank again the Academy for this opportunity. And I think the number of registrants and the number of people participating in this webinar talks a lot for the importance of international cooperation. And as Jill has mentioned before, you know, something very good comes out of a bad situation now. My task is to discuss surgery for Tetralogy of Fallot, the way we do it in Saudi Arabia. I would just say maybe at King Faisal Specialist Hospital, the hospital that I work in, and then just touch a little bit on the post-operative management. This is a logo for our congenital heart defects registry, and the reason I'm bringing this is a registry that we try and collect all the information about the patients that we are dealing, congenital cardiac patients that we are dealing with. And I just wanted to bring to your attention the fact that with the improvement in the infrastructure and etc., the number of patients that are being referred to the hospitals is increasing, and also the age at which the referral is happening is increasing. And you can see from this pie chart that 52% of the patients are referred to the cardiac centers in Saudi Arabia at less than 1 year of age. And we got about 5% referred at birth, and about 38% referred beyond 1 year of age, and only 5% are referred at older age. And if you look here, if you look at the patients that were born before 2001 and those era after 2001, you can clearly see that we have a larger number of patients being diagnosed antenatally, and the larger patients being referred to the hospitals in the latter era at a much younger age, less than 1 year of age. And this, of course, will lead us to seeing the patients much earlier and avoid what you can see in the picture of this severe clotting and cyanosis of late presentation of a patient with Tetralogy of Fallot. Unlucky, very rarely that we see this kind of presentation at the present time. Now, this experience kind of comes from managing almost 1,000 patients that had the tetralogy repair at our hospital. The age varied from 1 month to 42 years, but the median was around 11 months. And with the latter era of the experience, the age of the patients, as we will see, is younger and younger. And about 15% of our cohort underwent a prior one or more palliative procedure. If we kind of look historically at our experience, initially small babies were palliated if symptomatic, and surgery in asymptomatic children is deferred till about 5 to 6 months of weight or beyond about 6 months of age. However, this has changed with experience experience and improve the infrastructure. Currently, we offer correction to symptomatic patients irrespective of age and weight. And in asymptomatic children are usually electively repaired around 3 to 4 months of age. And as a policy, we don't see any reason in any patient to delay the repair beyond 6 months of age. However, palliation may still be needed. And when it is, our policy, mostly we will do a systemic to pulmonary artery shunt, which is generally a modified bleoloctausic shunt with a Gore-Tex tube. And this can be, depending on the preference of the individual patient, made through a thoracotomy or a median sternotomy. Occasionally, we have seen a very low birth weight babies with Tetralogy of Fallot, and in those patients, we do a classic bleoloctausic shunt just because of the size of the baby. And of course, with the interventional cardiologist, some of the patients are suitable for careful partial balloon dilatation of the right ventricular outflow tract and pulmonary valve, plus minus stenting. One, of course, has to be extremely careful doing this as not to overdo it and then cause flooding of the lungs and risk development of pulmonary vascular disease. At the present time, some of the reasons that would push us towards palliation include small or disconnected pulmonary arteries. If there is an anomalous major coronary artery crossing the right ventricular outflow tract, and that the patient will likely require a right ventricle to pulmonary artery conduit for the repair. And occasionally in patients with associated complex extracardiac anomalies, like a patient who presents with Tetralogy of Fallot and at the same time has a tracheoesophageal fistula. Emergency presentation is another thing that probably the patient will end up having a palliation. It all depends on the timing and the seriousness of the presentation. Some of those patients may be suitable to go for a primary repair, even if their presentation was an emergency. In the preoperative assessment, we really require from our cardiologists to have a good delineation of the anatomy of the central pulmonary arteries. We need to have a good look at the aortic arch, the ductus, and have to rule out the presence of any coarctation. We also would like to exclude additional muscular ventricular septal defects that in our series we have seen about 3% of the patients. We also like to exclude the anomalous coronary artery crossing the right ventricular outflow tract, which can be existent in about 4% of the patients. We also like to know if there are other multifocal pulmonary arterial supply to the pulmonary arteries. Most of the time, echocardiography can identify infants who are suitable for palliation or primary surgical repair. At the present time, angiography is reserved principally for those with complex pulmonary arterial anatomy or to delineate the coronary anatomy if there is any doubt from echocardiography. And of course, if there is any intervention that is required. If there are what we feel significant aortopulmonary collaterals, these usually are coiled in the cath lab prior to surgery and generally maybe the same, like the patient is taken to the cath lab the day before and then has the surgery the day after, or if there is significant drop in the oxygen saturation after the collaterals are occluded, the patient goes to surgery directly from the cath lab. Just look at the basic aims of the surgery for Tetralogy of Fallot. We'd like it to, of course, we need to close the ventricular septal defect or defects if there are any additional defects. We need to deal with additional shunts if the patient has been palliated from before. Of course, you need to take down the shunt. If there is a ductus arteriosus that needs to be ligated, or if there is an atrial septal defect that also needs to be closed. Occasionally, however, if there is a patent foramen ovale, we may elect to leave that open in certain cases. And of course, you need to relieve the right heart obstruction at all all levels. This can be accomplished through multiple surgical approaches that can include a transventricular approach, can include a transatrial approach, a combined transatrial and transpulmonary, and occasionally just a transpulmonary approach only. We start usually with a right atriotomy, open up the atrium and try and evaluate anatomy, look at the atrial septum, ASD, pedant foraminal valley, maybe even evaluate the pulmonary venous drainage, look at the ventricular septum through the tricuspid valve, and then also evaluate the probability of being able to relieve the obstruction through the tricuspid valve, and hence that would be like a total transatrial approach. But even if additional approaches are required, we tend to close the ventricular septal defect through the tricuspid valve, and mostly we utilize a bovine pericardial patch for that purpose. Muscle resection is performed, and then the pulmonary valve is evaluated, maybe even by Hager dilators, and usually if we can do the total repair through the atrium, that would be preferred. In principle, we try to preserve the pulmonary valve. However, prior to going to a transalveolar patch, we aim to preserve the pulmonary valve annulus. Like even if we end up having to do a total pulmonary valvectomy, we believe that maintaining the integrity of the pulmonary valve annulus, even in the presence of pulmonary valve regurgitation, is better tolerated by the right ventricle than the case where there is a pulmonary valve regurgitation with a transalveolar patch. Then we also try and size the pulmonary arteries, the pulmonary annulus and the pulmonary arteries, and see if additional work needs to be done for that. When the pulmonary valve annulus is hypoplastic, or if we are unable to assess the branch of the pulmonary arteries, or if the right ventricular arterial tract obstruction could not be completely and fully relieved, we go next step, open the pulmonary artery, and evaluate the pulmonary valve through the pulmonary artery, size the main and left and right pulmonary arteries, examine the pulmonary valve, and see if it is possible to preserve the pulmonary valve and the annulus integrity. And this is always done before we decide to go for a transalveolar patch. This is the kind of view you see for the pulmonary valve. You can do a lot of work on the pulmonary valve through the pulmonary artery. You can do a commissurotomy. You can do some kind of repair. But then if the pulmonary valve annulus is good, or if you decide to preserve the integrity of the pulmonary valve annulus, if further work is required on the outflow tract, that can be done through a small ventriculotomy, and then you end up with two patches, one patch on the right ventricle and the other patch on the pulmonary artery, and the pulmonary valve annulus with or without the pulmonary valve leaflets is being preserved. If a transalveolar patch is required, we try and limit this to not more than 2 to 3 centimeter cut in the right ventricular outflow tract. And as you can see here, the pulmonary valve is worked on, and then there is a very limited patch. Part of the pulmonary valve is left in situ, and the transalveolar patch is on top and with a very limited ventriculotomy. However, if this is not adequate, then you may really have to cut a little bit more into the right ventricle and utilize a little bit larger patch. But even if a similar patch is required, we try and limit it to a very small ventriculotomy. And when we used to repair the Tetralogy of Fallot in the earlier days, we were very adamant to get rid of all the gradient across the outflow tract, and utilize redundant patches and etc. to make sure that there is no gradient. However, we know that now this is not necessary, and a small residual gradient is not a big problem if you leave it, and it's better to limit the ventriculotomy and the transalveolar patching. early in our experience, when we have to get rid of the pulmonary valve, we utilize the monocusp patches, but really we did not find this very helpful. And I know there are now multiple groups that would do various reconstructions with monocusp patches and have excellent results with those. But this has not been our experience, so we don't use monocusp patches at the present time. When to leave a patent foramen oval or a patent foramen ovale open, if this is left open, this would allow right to left shunting with maintenance of the cardiac output on the expense of decreased systemic oxygen saturation. And if there is concern about the RV pressure being high initially, if the RV diastolic dysfunction, if there is RV diastolic dysfunction due to effects of right ventriculotomy and pulmonary insufficiency, and when a transannular patch is used, if there is worry about ischemia, maybe a long aortic cross clamping, possibility of reperfusion injury in an immature and hypertrophied right ventricle. Under those circumstances, the presence of a patent foramen ovale may help in the postoperative management. If you look at our experience here, you can see that early on, almost 90% of the patients used to have a transannular patch. And as we tended, like everybody else, to try and preserve the pulmonary valve more and more, at the present time, you can see that about 57% of our patients would have a transannular patch. And I would say that most of these will have a very limited transannular patch. And about 40% end up with a total transatrial correction. Our hospital mortality for the whole group was around 2.3%, and we had about a 5.2% late mortality. Some of those late mortalities were related to some reoperations for whatever reason. When you look at the survival function, it was obvious that patients with pulmonary valve preservation have a better survival than those with a transannular patching. And then if we look at the need for pulmonary valve implantation, you can see that, of course, patients with transannular patching require pulmonary valve implantation, whether in the cath lab or surgically, much earlier, and more number of patients require that. However, some of the patients with pulmonary valve sparing also require pulmonary valve implantation. And I must say also, the rate of re-intervention for residual obstruction in the right ventricular tract was a little bit, was higher in the patients in whom we attempted to preserve the pulmonary valve. This is all about, I would mention about the surgical technique. Now just going quickly for postoperative management. And it's just like any other open heart surgery, but I would like to touch on the problem of the low cardiac output, which can be seen very frequently in patients with Tetralogy of Fallot. And we'll just go a little bit into the physiology. Following repair, about 50% of patients have evidence of abnormal right ventricular diastolic dysfunction, specifically what we call RV restrictive physiology in the early postoperative period. And this is seen at echo or Doppler finding of antegrade diastolic pulmonary arterial flow coincident with the atrial systole. Now, what happens also that that is basically, I think, it's really helpful physiology, that the antegrade diastolic pulmonary arterial flow is abbreviated, and the amount of pulmonary valve regurgitation is less because of that, which can be somehow a protective mechanism for the right ventricle. But nevertheless, the ventricle is stiff, and these findings reflect that the RV compliance is poor, and this gives the clinical picture of low cardiac output that can be seen in patients with Tetralogy of Fallot. That is manifested as pleural effusions, liver congestion, and sometimes even ascites. Therefore, if this happens, of course, you need to start inotropic support. And this needs really to be started early. Every unit has their own mix of inotropes. At one stage, we used to use dopamine and dobutamine. Now, most of the patients would actually have, if they require this, would have adrenaline or noradrenaline in addition to a vasodilator, which is mostly milrinone. We used to use phentolamine as an after-roll load reducer, but I think most of the patients now would end up on milrinone. Sorry, for some reason, yeah. And one thing also that we actually find very helpful in these patients is placing a peritoneal dialysis catheter, and sometimes just the mere drainage of the ascites would help the hemodynamics. But occasionally these patients would have a low urine output, and we prefer, rather than hitting the patient with diuretics, is to start peritoneal dialysis early. And again, that's a very rewarding strategy. The other thing that also happens in these patients is that there is a marked interdependence between right ventricle hemodynamics and respiration. The antegrade diastolic pulmonary arterial flow generally in these patients is augmented by spontaneous inspiration. The expiratory phase of positive pressure ventilation, the negative pressure ventilation with a QRS ventilator, and this is an interesting kind of historical note. I'll just allude to it a little bit later. Use of intermittent positive pressure ventilation at shortest possible inspiratory time and lowest possible mean airway pressure, and maintenance of sinus rhythm. So all these maneuvers are very helpful to try and improve the antegrade diastolic pulmonary blood flow and even reduce the deleterious effects of pulmonary regurgitation, and hence the improvement in hemodynamics. Just the mention, this is I don't know if maybe many of the viewers might not be familiar with the QRS ventilator, but this actually is historically used to be used before the endotracheal intubation for the management of patients with polio, where their respiratory muscles were very weak and they could not breathe. And the ventilator at one stage was trying to get a resurgence in the management of some patients with Tetralogy of Fallot and patients with a failed or poor Fontan circulation. However, for some reason, this was only kind of popular for a brief period of time, and I don't see this actually in any cardiac surgical unit at the present time. Maybe very few, but not very common. Early extubation is crucial, and I think all of the things that we mentioned that help the diastolic function of the right ventricle are improved by early extubation. So if the patient can be extubated early, that's really ideal. So to finish off, complete repair of the Tetralogy of Fallot can be accomplished with low morbidity and mortality, even if associated with additional complex problems. Complete primary repair is favored if anatomy allows. Pre-operation rate is acceptable. Surgical approaches need to be tailored in each individual patient to achieve total anatomic correction. And the post-operative low cardiac output is the commonest post-operative problem and is more common with transannular right ventricular outflow tract repair, and early extubation in general is preferred. Thank you.
Thank you very much. It was a very good presentation, and we have a lot of questions on Q&A. Means that people were really interested about this topic. Thank you very much. It was a very nice presentation. And just to clarify to everybody, we have this time CME points, but it's issued by the Saudi Council. So we are going to get a certificate. If you, all of the attendees are going to get a certificate of attendance. And if you're from Saudi, you're going to get your CME points uploaded on your account. If you are not from Saudi Arabia, you need to check with your country if CME points issued by Saudi Arabia are accepted for you. But the certificate of attendance we are going to get anyway. About the other meetings that I'm going to talk about in the break and that I've placed on the chat box, we can send you a certificate of attendance, but no CME points so far. These are from Congenital Heart Academy. Okay. So thank you for everybody who's placing their questions on the Q&A box. It's going to be very interesting to answer for you. And now I'm very happy to announce Dr. Laura Mercer-Rosa. She's Brazilian as me, but she practiced in the US. She's associate professor of pediatrics at the University of Pennsylvania and attending cardiologist at Children's Hospital of Philadelphia and director of the EchoLab Research Unit. And she's going to talk to us about imaging late after Tetralogy of Fallot. Welcome, Laura.
Thank you so much, Grace, for the kind introduction. Thank you to you, Sasha and Gil, and to the Saudi Heart Association for the invitation to be a part of this fantastic international webinar. It's really an honor for me to be able to speak to you about imaging and tetralogy of Fallot. Good morning and good evening to the world. I also want to send a heartfelt hello to the motherland. I know there are a lot of people in Brazil who are watching the webinar, so big hug to my fellow Brazilians out there. So we will talk about mostly today about the assessment of pulmonary insufficiency and right ventricular function after tetralogy of Fallot repair. And we all start looking at these echocardiograms with the overall assessment, or what I refer to as eyeballing. And you can see here on this image on the left, which is an apical four-chamber view, demonstrating this very remodeled, very abnormal appearing right ventricle. It's significantly dilated. It has this classic shoulder appearance that we only see in very dilated hearts. And also a broad apex, and the right ventricle appears to wrap around the left ventricle, and it's much larger than the left ventricle. And we can also appreciate the ventricular function here. But please notice that this is what we call a RV dedicated four-chamber view, because as these patients get older, it's very hard to get the RV in the picture. It's also very hard to be able to see the delineation of the endocardial borders. So we need to be conscious about the fact that we need to bring the right ventricle into the picture. Here's a short axis view of the same patient demonstrating the significantly dilated right ventricle. You can see that the septum flattens in diastole, but it's rounded in systole, and therefore it's pretty safe to assume that this looks like it's purely a volume-loaded right ventricle. On the right, we cannot forget that in the long term, there are other problems that arise in these patients, including a significant aortic root dilation, as we can see in this patient. So if we were doing this presentation live, I would now ask for a show of hands to ask how many of you think that these images belong to an adult patient repaired for tetralogy of Fallot. And I'm sure I would see a lot of hands raising. And it turns out that this is actually an echocardiogram from an 8-year-old patient who followed actually this unnatural history of tetralogy of Fallot repair. We heard a lot about this already in the prior two talks, but this patient had this early elective repair at age 2 months, but had a very severe anatomy with what was described as a pinhole orifice to a very thickened and small pulmonary valve, received a transannular patch, access through a ventriculotomy. The patient then required an early reoperation for residual outflow tract obstruction, plasty of the left pulmonary artery and closure of the atrial septal defect, and then had a balloon angioplasty of the LPA at age 1. So this patient is now 8 years of age and is already seeing the effect of the residual lesions on this heart. So we now are going to focus on the assessment of residual pulmonary insufficiency. And here is a apical view with anterior angulation demonstrating the right ventricle with a wide open right ventricular outflow tract. And you can see that there is this wide, pretty significant jet of pulmonary insufficiency. And in this view, we can actually also see the branch pulmonary arteries. Notice how the left is smaller than the right in this patient with this very broad jet of pulmonary insufficiency. And as we move to the short axis view, we can see the same information, but see how far into the pulmonary arteries we can see the reversal of flow from pulmonary insufficiency. So now we're going to talk a little bit about how to use the Doppler interrogation of the main pulmonary artery to better assess pulmonary insufficiency. So I'd like to bring your attention to this very interesting and good publication that came out as a guideline from the American Society of Echocardiography, first authored by Anne-Marie Valenti from Boston, which proposes multimodality imaging guidelines for the assessment of tetralogy of Fallot patients after repair. And I really like this figure that's in the document that really exemplifies the Doppler patterns at different severity of pulmonary insufficiency. As you can see here on the left, in cases where there's mild pulmonary insufficiency, there is this jet that extends all the way to the end of diastole. And there's really never equilibration of pressures at the end of diastole, as you can see here. And if sampling a branch pulmonary artery, there is no flow reversal. Now let's look at the extreme of severe pulmonary insufficiency. And this is the classic appearance with an acute drop in diastole with fast equilibration of pressures. And this is the classic appearance of the Doppler interrogation in severe pulmonary regurgitation and Doppler sampling distally the branch pulmonary artery. It also demonstrates the flow reversal, which we already saw by collar interrogation. And the moderate insufficiency is in between, but please notice that the Doppler pattern actually resembles much more the severe type of insufficiency. So here are some real life examples. The patient I just showed you with that abrupt drop in the pressure. We also know that this patient has no residual outflow tract obstruction, but if you notice here, there is turbulent flow across the outflow tract. Here's an example of that very mild jet of pulmonary insufficiency. And finally, I'm not going to get into the restrictive physiology that was mentioned earlier, but I just want to say that in the long-term follow-up, we only see this phenomenon of antegrade and diastolic flow in the main pulmonary artery in situations where there is pretty significant pulmonary insufficiency. So we always try to quantify things by echocardiogram, comparing against the gold standard. And the gold standard that we use most of the time is the quantification of these hemodynamic derangements by cardiac MRI. So many years ago, we decided that we wanted to improve how we quantify regurgitation by echo, and we used a research cohort of tetralogy of Fallot patients who were between 8 and 18 years that had concurrent echocardiograms and cardiac MRIs, and the study was led by Betsy Goldmans at CHOP, and we identified 143 patients that had both echo and MRI. And we decided to trace the diastolic jet and the systolic jet here. And that gives us the integral of the velocity over time, which is a better estimation of flow across the main pulmonary artery. So we divided the diastolic over the systolic and got the ratio. And it turns out that we actually were able to identify cut points for this ratio that were corresponding to mild regurgitant fraction by MRI and corresponding to severe regurgitant fraction by MRI, which is greater than 40%. So after we conducted the study, we decided that we needed to actually validate this ratio, and we identified a subset of that cohort that had undergone clinically indicated MRIs at a follow-up of about 5 years. And we again identified that there was a significant correlation between our ratio and the regurgitant fraction, and we used the cutoff value of 0.68 for the ratio to really distinguish between mild and severe pulmonary regurgitation. But the first important finding of our follow-up study was that the regurgitant fraction did not change over the follow-up period of 5 years. Both the ratio and the regurgitant fraction remained the same. But we noticed that, in fact, what really changed over those 5 years was how the right ventricle remodeled and further dilated in response to this pulmonary insufficiency. As you can see here, the volumes went up. And we also identified a preserved overall ejection fraction in the cohort, but we noticed that there was a drop in about 3 points in ejection fraction over the study period. So we then asked, so what makes a ventricle dilate more than the other? And in our multivariable analysis, the only factor that was associated with how much the ventricles dilated over the follow-up was how they started off. So how dilated they were at their baseline MRI. And remember that those were research indicated. So some patients had their first MRI when they were 8 years old. So the more dilated these ventricles are, they seem to dilate even more. This is a little counterintuitive, but made us think more about the right ventricle itself in Tetralogy of Fallot. So we then turned our attention into how to better assess right ventricular function in this patient population. So before we do that, I just wanted to put two important concepts into perspective. One of which is the normal contraction pattern of the right ventricle. As you can see in this video, the normal right ventricle has a very robust shortening along the longitudinal axis, as you can see here by the pulling of the tricuspid valve annulus towards the apex. And there is a smaller contribution to shortening from the right ventricular free wall, which has a bellows type of motion towards the ventricular septum. So this is the normal contractility pattern in the normal right ventricle. But let's now talk about what happens in the heart in Tetralogy of Fallot, which is very far from normal. This is a study from Professor Anderson and his group from more than 20 years ago, where they examined specimens of tetralogy hearts. And upon examination, even the superficial myocardial layer of the heart, the right ventricular fibers are actually in a different orientation as compared to the normal heart, as you can see here. And a very important feature is that the heart in Tetralogy of Fallot develops a circular middle layer, which is not present in the normal right ventricle. So it's very possible that these abnormalities or changes in the architecture of the right ventricle, along with possible development of fibrosis, which is a very hot topic in tetralogy right now, it's possible that these mechanisms are somewhat associated with the long-term electrical and mechanical problems we see in these patients. So finally, this is putting those two pieces of information together. It's a very nice review of three-dimensional echo decomposing the motion of the right ventricle, and again demonstrates the normal right ventricle with a lot of longitudinal shortening, some radial shortening from the free wall, and some anteroposterior shortening, which is the short axis view. And here's what happens after tetralogy surgery. As we saw in our first example, the right ventricle becomes elongated, dilated, and loses that longitudinal contractility. And there is a somewhat compensatory, if you will, increase in the radial shortening with no change in the anteroposterior dimension. So now let's go back to the guidelines paper that was published 6 years ago, and let's go over the measurements that were suggested in that publication. And TOPSI, which I alluded to as the tricuspid annular plane systolic excursion is really the motion of the tricuspid valve annulus towards the apex, which is very robust, as you can see in this representation on the left in the normal heart. And it is decreased in this patient after tetralogy of Fallot repair. Very easy to measure, very reproducible. The tricuspid velocity, the tissue velocity of the tricuspid valve in systole is really the same as TOPSY, but it's a velocity, not a distance. So these parameters should always mimic each other. But from what we just talked about, we have to conclude that we should not use TOPSY alone to assess the right ventricle in tetralogy of Fallot. So many years ago, when we started this quest for a better assessment of the right ventricle by echo, we went back to the same research cohort and identified 125 patients that had cardiac MRIs and did TOPSY measurements in all of those patients. And what we found was that TOPSY was markedly reduced in the cohort across the board. And we knew that that cohort had preserved RV ejection fraction. It was 60%. So you might be already guessing what the correlation was between TOPSY and ejection fraction. It was this: none, zero, the worst possible scatter plot an investigator can ever have. There is no association between ejection fraction and TOPSY indexed adjusted for age in any way, shape, or form. So at least we showed that indeed, after tetralogy of Fallot repair, there is a significant decrease in the longitudinal shortening of the right ventricle. In fact, that longitudinal shortening is very sensitive to many things, including to the integrity of the pericardium. So just limited use for TOPSY, but I want to show you that the Austria group has done a lot of work in this, and they have shown that over the years, TOPSY in these patients gets even worse. So now we're going to talk about another parameter called the fractional area change, which is a better parameter because now we're talking about area. And it's the tracing of the RV on the cardial border in end diastole and end systole. And that gives a fractional area change. This is better because it uses the contribution of the free wall to right ventricular shortening. However, it requires tracing of that border and good windows and good pictures. And we need to be able to see the RV in order to trace it. So in our hands and others, when done for research purposes in very trained personnel, it's extremely reproducible, but I must confess that when I am tracing those RVs, I am not consistent with myself, and I am very, I would be very cautious about using a parameter that's so inconsistent, but it's there. And I will show you this example of how hard it is to guess where the endocardial border is for this patient with a very dilated right ventricle. But you can see that this robust fractional area change is mostly on the account of the motion of the tricuspid valve. And in fact, this is a young tetralogy patient, 2 years old, who has a very robust TOPSY, which measures normal as compared to adult values. So finally, we're going to now talk about the use of strain to assess right ventricular function after tetralogy repair. And strain is also known as myocardial deformation, speckle tracking. There are many names, myocardial mechanics. But the basis for strain is to use the speckles from the myocardium that are produced by the ultrasound and to make measurements in each segment, which is the difference in length in end systole minus end diastole. So by definition, strain is always a negative number, and the more negative the values, the better the function of the myocardium. So why should I propose to use strain after tetralogy of Fallot repair? In addition to there being a lot of data, and this is not exhausting list, there are a lot of data, many studies using echocardiogram, cardiac MRI in tetralogy of Fallot. But we should use strain because it is actually very reproducible. The tracking of the myocardium is independent of the angle of interrogation and the geometry of the right ventricle, which becomes very exciting to use in tetralogy of Fallot, as well as the adjacent motion and tethering of the other structures. Strain appears to be a sensitive parameter where it gets abnormal before we see over changes in function by ejection fraction. And what's great now is that some of the machines that we use actually have auto strain. It's built into the machine, and therefore we're able to measure strain very fast at the bedside in about 1 minute. And it incorporates all the segments of the right ventricle, or if one prefers, just to measure the shortening of the free wall. So here's data that we were looking for when we started considering using strain. And this is from more than a decade ago from the Netherlands. And these investigators used baseline and follow-up at 4 years strain measurements in adult patients with Tetralogy of Fallot. And what they showed when they compared these patients to changes by cardiac MRI was that there was no change whatsoever in 4 years in their ejection fraction. In fact, the numbers here are exactly the same. However, they did notice that there was a 3-point drop in strain over 4 years. So perhaps this is the evidence that we were looking for to say to us, yes, I think strain probably goes down before we see changes in other parameters. So another study also from the Netherlands, who now examined strain in Tetralogy of Fallot as compared to controls, and they used the different segments of the RV, and they found that in every segment, as well as the global longitudinal strain of the RV, was significantly diminished as compared to controls, and that the worst or the most marked difference was in the apex of the right ventricle. And in this group, they also showed very good reproducibility of their strain measurements. So finally, I'd like to get towards the end of this presentation just by saying a couple of words about what happens with the heart after pulmonary valve replacement. And I like to refer to this as the reverse remodeling that we expect to see in the right ventricle when we volume unload that ventricle by giving the patient a new pulmonary valve. So here's another example of a very remodeled right ventricle, extremely dilated, prior to pulmonary valve replacement. This is at 17 years of age. And here's the same patient 4 years later with a well-functioning pulmonary valve. But you can see that this heart doesn't really look good. It's not entirely reverse remodeled. It's still very dilated. And if you look at the function, it does not look normal. And in fact, the real-time strain on this patient did demonstrate that the global longitudinal strain was diminished at -13, in particular at the apex. So we actually asked this question: what makes a person be a better remodeler or a worse remodeler? So in collaboration with Yuli Kim from the adult congenital group at our hospital, we set out to do measurements by echo in patients before and after pulmonary valve replacement, 1 year after PVR. And these are the measurements that we did. And again, one more example of a very sick looking right ventricle in a patient with a pacemaker, but after a year of pulmonary valve replacement, there was really no evidence of reverse remodeling of this right ventricle as compared to this person who had a significant improvement in the right ventricular size, but also has evidence of very robust shortening, and as you can see with the motion of the free wall here. So what makes one person a good remodeler versus a bad remodeler? And the only thing we found in the study is that when they were younger at pulmonary valve replacement, they remodeled better. So I just want to throw that out there as a thought. So in summary, why should we continue to persevere to assess right ventricular function in these patients at different stages? Well, we know that when they're younger, their ejection fraction is preserved. We found this in our cohort, and others have found the same. But we also know that when RV dysfunction develops in adults, it's associated with increased risk of death. And this is very important data from the indicator cohort, relatively young patients at 24 years, that a 3 times hazard of death in patients who had right ventricular dysfunction. So we continue our research and the search for when the tipping point of the right ventricle occurs. We still don't know, but we should definitely continue to refine the assessment of right ventricular remodeling and function. And with that, I'll just say that I'll continue to go with the flow. Thank you so much.
Laura, thank you. That was just fantastic.
Thank you, Gil.
There's so much that we know more now in the last 10 years, but all that does is bring up so many more things we don't know.
Yes, indeed.
That's the process of this whole event, this journey of Tetralogy of Fallot. I am really happy to introduce our last speaker before the halftime break, who is a colleague of mine and I'm very fortunate to work with every day, Dr. Elizabeth or Libby Sherwin. She's a pediatric cardiologist and electrophysiologist here at Children's National Heart Institute. She's an associate professor at the George Washington University. She's a fantastic clinician. She trained up at Boston Children's with Ed Walsh and John Triedman and all the excellent electrophysiologists up there. She was in Canada for a while before she returned back here. And she's in all of the important societies, the Pediatric and Congenital EP Society, et cetera. Her specialties are in inherited arrhythmias, and she'll be speaking with us today about arrhythmias early and late after Tetralogy of Fallot. Thank you for joining us, Libby.
Thank you, Gil. It's wonderful to be part of such an amazing group and fantastic talks already. And great to be with people from around the world. I love seeing all the hellos and the comments. So we're going to talk about arrhythmias early and predominantly late after Tetralogy of Fallot. Much of the action is in the older patients. If I can now get my slides to go. So there's many reasons why patients with Tetralogy of Fallot will have arrhythmias. Like many of our congenital patients, there are anatomical substrates or mechanisms. Surgical scars play a big role that we'll talk about. And then acquired and chronic arrhythmia risk factors that accumulate over the course of a lifetime. And these arrhythmias are a leading cause of morbidity, impaired quality of life, and mortality among patients with Tetralogy of Fallot. So in general, with adult congenital heart disease, of course, we're looking at multiple types of arrhythmias: sinus node dysfunction, heart block, atrial arrhythmias, AV reciprocating tachycardias between the atrium and the ventricle, ventricular arrhythmias, as well as heart failure, not direct arrhythmic problems, and sudden cardiac death. When it comes to Tetralogy of Fallot, we know that those risks increase with age, and we primarily talk about the atrial arrhythmias, ventricular arrhythmias, and sudden death. However, they are susceptible to all of the others as well. Among tetralogy patients in adults, the incidence of atrial arrhythmias is thought to be 20%. 14% will have ventricular arrhythmias, and the risk of sudden death is, over a lifetime, approximately 2% per decade, though that does increase with each decade of life. Again, thinking about all comers with congenital heart disease, the substrate for arrhythmia may come from chronic pressure, volume dilations, valve regurgitation. Sometimes the electricity is inherently different based on the anatomy. Chronic cyanosis or hypoxia, periods of acidosis affect the myocardium and the electricity, as well as other abnormalities of the myocardium itself or potentially the coronary arteries. The post-operative state is even more ripe for arrhythmias, with sinus node dysfunction, atriotomy and ventriculotomy scars, which are particularly relevant for our tetralogy patients. Scar is a great place for an arrhythmia to generate or to wrap around. Potential for AV node injury, patches within the heart that create areas of slow conduction that we'll discuss. So numerous reasons why patients can have arrhythmias. And in Tetralogy of Fallot, the greatest risk factors or causes of arrhythmias would be the patches, the right ventricular outflow tract if they had one, a VSD patch, potentially an ASD patch. There's chronic pressure and volume load on the right ventricle, which leads to chronic changes. There's right ventricular conduction delay, which leads to dysynchrony between the two ventricles and alteration in function. Of course, patients, many may have an atriotomy scar, as we heard about this morning. And although the risk is low, some patients will develop AV block or heart block and require pacemakers. When we think about kind of what the baseline looks like, what does our baseline electricity look like? Well, preoperatively, patients typically have right ventricular hypertrophy from the pulmonary stenosis. This shows up on an electrocardiogram as dominant right-sided forces, R waves in V1 and S waves in V6. They will have persistent T waves, which are normal in a newborn but should invert they will persist and be upright in many cases, suggesting right ventricular hypertrophy. In the postoperative state, virtually all patients will have right bundle branch block, and that's a result of potentially both surgical injury to the conduction system at the time of VSD patch closure, as well as right ventricular dilation from ongoing pulmonary regurgitation. This develops into right ventricular remodeling and fibrosis, which also slows the conduction through the right ventricle, leading to conduction delays on the electrocardiogram. And patients can often have first-degree heart block that tends to be from atrial dilation, so a longer duration of the signal going from the sinus node to the AV node, rightward access, and right atrial enlargement. Here's an example of a 6-week-old unrepaired tetralogy of Fallot, and the baby does have prominent right ventricular forces with R waves here in V1, slightly enlarged S waves in V6. They're not terribly striking for a 6-week-old. Early arrhythmias in tetralogy of Fallot really are dedicated to the postoperative time frame. There's not an increased risk potentially or necessarily of arrhythmias prior to surgical intervention, though patients are often on beta blockers for cyanotic spells. Postoperatively, what we predominantly see is junctional ectopic tachycardia. In 2 studies, one in Germany and one in Saudi Arabia, they found between 13 and 30% of patients undergoing primary repair of tetralogy of Fallot had JET. The risk factors for this were patients who were repaired at a younger age, longer cardiopulmonary bypass time. One study reported higher preoperative heart rates being a predictor of JET post-op, lack of preoperative beta blocker use, and of course, electrolyte imbalance, which goes for any postoperative patient. Another study by Dr. Brad Clark here at Children's National showed that among patients with ectopic atrial tachycardia in the postoperative period, 12% of those patients with EAT were tetralogy of Fallot. So certainly JET is not unexpected and is the most common that we see. This is an example of a 7-year-old patient with repaired tetralogy of Fallot who presented with palpitations. And many of us will recognize quickly that this is not a normal electrocardiogram. However, not everybody is quite as familiar, and this patient was seen in an emergency room, was given a dose of adenosine with reportedly no effect, and was sent home for close follow-up in the outpatient clinic. However, one notable fact is that this patient's baseline heart rate is 60 beats per minute. So this heart rate here before the pause is greater than 150 beats per minute, clearly tachycardic. And we can also notice that there's an abnormal P wave morphology during the tachycardia, and certainly here during the pauses, we get to see the flutter waves come out. So this is atrial flutter in a 7-year-old, relatively young. Over the course of time, the normal electrocardiogram evolves into this 50-something-year-old adult patient with tetralogy of Fallot. And what we see here is atrial pacing with the small pacing spikes. There's intra-atrial conduction delay. So from the spike to the P wave, there's some delay, making a PR interval longer. And of course, our right bundle branch block with this patient having a QRS duration greater than 200 milliseconds. So we talked about the bread and butter of really arrhythmia management in tetralogy of Fallot is in the adult congenital patients. This is an important paper shared by Dr. Carey in Canada, and it was a Pediatric and Congenital EP Society and Heart Rhythm Society consensus statement on arrhythmia recognition and management in adults with congenital heart disease. Of course, this includes all comers, and this very busy slide is simply to show that it breaks down congenital heart disease from simple to moderate to severe lesions. And then it talks about different arrhythmias and the risk, being high risk in dark blue, moderate risk in medium blue, and mild risk in light blue. Focusing in here a little bit on our moderate complexity, we see that tetralogy of Fallot does, of course, fall in the moderate complexity range. And where the arrhythmias are at greatest risk would be atrial tachycardia, atrial fibrillation, ventricular arrhythmias, and of course, heart failure. This is another important paper for people managing adult congenital heart disease or even giving guidance to young families who are growing up with this condition. Stout and all with the American Heart Association and the American College of Cardiology developed guidelines for management of adult with congenital heart disease. I particularly like this paper because it breaks down individual lesions, and it gives not only historical physiologic guidelines, but also monitoring. So for rhythm surveillance in an asymptomatic person with Tetralogy of Fallot without known arrhythmia conditions, these are the Tetralogy of Fallot routine follow-up and testing intervals as recommended based on the physiologic stage, which equate roughly to heart failure classes. And we can see that electrocardiograms, Holter monitors, and exercise stress tests are recommended for routine surveillance if there are no clinical concerns at 1 to 2 year intervals. Of course, many patients will be symptomatic or have incidentally noted arrhythmias. Again, from an all-comer perspective in congenital heart disease, 15% of patients will have atrial arrhythmias, and these are associated with significant morbidity and mortality. Having an atrial arrhythmia increases the chance of any adverse event, mortality, of course, stroke or heart failure, and the need for cardiac interventions. So these are important to recognize. The risk factors that have been described for atrial arrhythmias would be a late repair, meaning older childhood, 5, 6 years of age, a history of a palliative intervention, such as a shunt, prior to their complete repair, and having significant tricuspid regurgitation, which of course leads to atrial stretch and atrial arrhythmias. Atrial flutter is, of course, the most common. With typical flutter, we call it cavo-tricuspid isthmus-dependent flutter. But there are also many other reentrant arrhythmias in the heart, such as intraatrial reentrant tachycardia. And I'll show pictures of those in a moment. So this can be difficult to recognize. We all know the sawtooth flutter classic description. However, in an adult congenital, an atrial flutter circuit, which is the loop it's taking, might be much slower because the atrium is larger. So this, although the ventricular rate is 75 beats per minute, not terribly tachycardic, we do see flutter waves when we look closely. In many non-specialty centers, an emergency room might have an easy time missing this because the pulse rate is normal and the flutter waves could be attributed to noise or T-wave abnormalities. So one of the clues that I always talk to our fellows about is be very suspicious for atrial tachycardia and atrial flutter if the resting heart rate is higher than baseline. Just like our 7-year-old should not have been at 150, this 50-year-old should not have been at 75 beats per minute at rest. Their baseline is quite low, typically. So these are two 3D maps of atrial reentrant or atrial arrhythmias. So just for quick orientation, these are 3D non-fluoroscopic timing maps during an atrial tachycardia, where the color bar is the earliest signals in the red, and along the rainbow spectrum, the latest signals in the purple. So in this, on our left side of the screen, is a typical atrial flutter, where the superior vena cava is at the top, the IVC is at the bottom, and this area in yellow tends to be more the tricuspid valve orifice. And here we see the pattern of this atrial rhythm rotating around the atrium in a counterclockwise loop. That's typical flutter. This area marks an area of slow conduction, which is required for reentrant arrhythmias. Here, we have a non-typical atrial flutter. We have an intraatrial reentrant tachycardia, where we can see that the timing is rotating around what would be an atriotomy scar in the high right atrium. So this is also reentry, but it's at a much faster rate because it's a shorter circuit around this atriotomy scar. Though we don't see it as much in the younger patients at all, we certainly do see atrial fibrillation in the adult congenital population. One study of a simple atrial septal defect population showed that 1/4 of patients will develop atrial fib. At a Mayo Clinic study, looking specifically at Tetralogy of Fallot patients, 21% of Tetralogy patients had atrial fibrillation. And having this particular arrhythmia portended a 4 times higher risk of hospitalization for heart failure. It's also associated with reduced survival. So this is an important one for us to be mindful of. Here's an example of a tetralogy patient, right bundle branch block. And for the most part, the baseline is relatively flat, but in V1, it becomes very obvious that this is indeed atrial fibrillation. Similar to many adults, this is if it is symptomatic and or refractory to medications, it can be considered a class 2A indication for pulmonary vein isolation or atrial fibrillation ablation. All right, moving on to the ventricular arrhythmias. This is, some might think, the bread and butter of arrhythmias in Tetralogy of Fallot, but both atrial and ventricular arrhythmias are prominent and important. But ventricular arrhythmias are fairly unique among tetralogy of patients because of both their native anatomy and because of their surgical interventions. So with the native anatomy, we see that there are islands of muscle between various points. So for example, between the VSD and the pulmonary valve, there's a band of muscle that comes around here. The VSD itself can act as a central inert or inactive electrically area around which an arrhythmia can rotate. So most ventricular arrhythmia in Tetralogy of Fallot is macro reentry within the ventricle using these zones of slow conduction and different areas of conduction blocks, such as a VSD patch. Again, a 3D map version of this, where we have the color of the timing of the arrhythmia, and the gray area represents scar. There's no electrical voltage here and no rhythm passing through here. So this is a ventricular tachycardia that's rotating around the RVOT patch from the initial repair. This information is really helpful to use both for transcatheter ablation and intraoperative ablation at the time of future surgical interventions for patients. So Zeppenfeld did the original work with this, which was really important in identifying these areas of greatest risk, or these channels that are targets for ablation. Here, if we denote these red dots to be ablation lesion sites, we can create a line of ablation from the RVOT patch to the tricuspid valve annulus. Similarly, it can be from just a ventriculotomy to the tricuspid valve annulus, from the ventriculotomy scar to the pulmonary valve, or from the VSD patch to the pulmonary valve and to the tricuspid annulus. And what these do is they create a line of blocks, so there's no longer a loop or a circuit around which that rhythm can rotate. Part of the reason for that is morbidity, but really the goal of reducing these ventricular arrhythmias is mortality. So we know that patients with Tetralogy of Fallot are at risk of sudden death. Among congenital heart disease, they're some of the highest risk patients. And this can be secondary to both atrial and ventricular arrhythmias. SVT is not so simple in an adult congenital patient. Ventricular arrhythmias, though, are the leading cause of mortality in Tetralogy of Fallot, again, about 2% per decade or 0.2% per year. Among patients receiving ICDs with congenital heart disease, tetralogy is the most common indication. There have been many attempts to define who is at risk for sudden death and these malignant arrhythmias. There are classically described risk factors and some newer and evolving clues to this. So early reports have always described that having a transannular RVOT patch repair creates a risk, one of the greater risks for sudden death due to arrhythmias. We all know on the electrocardiogram the classic description of QRS duration greater than 180 milliseconds being a risk factor, though there's a lot more interest and study in looking at QRS fragmentation, or the number of spikes within the QRS, as being a better indicator than simple duration. A history of non-sustained ventricular tachycardia or inducible sustained ventricular tachycardia during an electrophysiology study. Having moderate to severe pulmonary regurgitation and the resulting RV dilation, of course. Any degree of left ventricular dysfunction is felt to be a risk factor. From an imaging standpoint, this is great lead up from the past presentation. Both echocardiographic and MRI findings, including extensive scarring in the right ventricle, of course, scar being a great focus for arrhythmia development, as well as left ventricular strain by echo and left ventricular circumferential strain by MRI as independent risks for VT. So how do we prevent it? We know a lot of risk factors that many patients will have. Of course, medications are a mainstay, and we don't have time to go into all the medication options, but beta blockers being number one for Tetralogy of Fallot. Transcatheter ablation is an important therapy, and has become quite successful. It's really evolved a lot over the last 10, 15 years, particularly with the aid of the non-fluoroscopic mapping that I showed, which can really identify areas of scar, areas of slow conduction, and precise mapping of where these arrhythmias are originating. For atrial arrhythmias and flutter, the current success rates are approximately 85%. Not 100%, but quite good for 85%. For ventricular tachycardia, the catheter ablation success rate is a bit lower, approximately 70% in the long run, with acute success being higher, but the risk of recurrence being up to 20% in most studies. Certainly higher than SVT in a structurally normal heart, but given the complexity of these ventricles, still quite successful. There's also a lot of interest and attention given to intraoperative cryoablation at the time of another surgical intervention, such as pulmonary valve replacement. Utilizing that same anatomic information, we can create cryoablation lines in the operating room. A recent report by Sandhu et al. Showed that the success of this was 55%, so not perfect, but more than half will have benefit of reduced VT risk. Defibrillators, of course, in addition to ablation, are a more definitive and longer standing arrhythmia therapy and prevention of sudden death. But despite all the known risk factors, we still don't have an easy time to define an algorithm for who should get a primary prevention ICD, meaning implant before they have an arrest or a malignant arrhythmia in order to prevent that from occurring. These, of course, are associated, like any patient, with a high risk of inappropriate shocks or other complications, but also the patients who do have primary prevention ICDs in Tetralogy of Fallot have a 25 to 30% chance of appropriately using their defibrillator, which is quite good. So in deciding who needs a primary prevention ICD, we do utilize standard adult criteria, but then we also have to consider the tetralogy patient, even without left ventricular systolic dysfunction, to consider whether or not they should have one. And all of the guidelines will use language similar to this, what's shown here from Stout and all, that ICD therapy is reasonable in select adults with Tetralogy of Fallot to consider who have multiple risk factors. So it doesn't define how many you have or how severe those risk factors have to be. It's much more the art of medicine and a subjective, individualized decision. In 2017, the American Heart Association, American College of Cardiology, and Heart Rhythm Society also developed guidelines for management of ventricular arrhythmias in all patients. And what I love about this is that it's the ischemic, the standard adult patients, but also includes congenital heart disease, which is often separated from many guidelines in adult cardiology. But similar to the other, again, in a repaired Tetralogy of Fallot with high-risk characteristics, we may consider an EP study to see if they're inducible and or if they have multiple risk factors to consider an ICD. They also talk a little bit about medication management. So for an adult with repaired tetralogy and frequent ventricular arrhythmias, beta blockers would be strongly encouraged or considered. And if they have symptoms such as unexplained fainting or moderate dysfunction or hypertrophy, then certainly doing more invasive risk stratification and consideration of an ICD is warranted. Back to the Stout guideline, again, just the multiple risk factors being a pretty nondescript, but tailored and individualized guideline. I do want to talk about pulmonary valve replacement. So Dr. Mercer-Rosa beautifully introduced this, that the dilation doesn't necessarily go away after pulmonary valve. Part of the stress of the right ventricle is that big volume load and the dilation, but taking away the volume load by replacing the valve has been shown in several studies to not eliminate or significantly reduce the ongoing risk of sudden death, reported in 4 to 8% of patients in the years after a pulmonary valve replacement. So it's important for us to maintain vigilance and even plan for this before their surgery. So many groups will elect to do preoperative EP studies to see if patients are inducible, both to help manage their perioperative arrhythmias as well as their postoperative risk. We can also do this in the operating room and guide interventions for the surgeons in terms of ablation. One note before closing on resynchronization therapy in Tetralogy of Fallot. This is more of an up-and-coming potential therapy. So we all know that cardiac resynchronization is utilized with biventricular circulations to do biventricular pacing to augment function in heart failure. In a single ventricle patient, we might do dual site ventricular pacing, such as hypoplastic left heart syndrome. There have been multiple ways of doing this for the right ventricle itself in Tetralogy of Fallot, so focused RV resynchronization. This can be done acutely, post-operatively, by placing epicardial temporary pacing wires at the sites of latest electrical activation, so that those can be timed early, paced early, bringing the ventricle into a more synchronized contraction and augmenting function in the acute post-operative time period. This has also been tried for chronic permanent right ventricular pacing by placing typically epicardial pacing leads at the site of latest activation, thereby activating that early and trying to tighten the timing of the right ventricular contraction. This is more difficult to do transvenous and is typically done in conjunction with cardiac surgery for pulmonary valve repair. In summary, atrial and ventricular arrhythmias are both frequent and very important in Tetralogy of Fallot. The risks increase with age, and they both contribute to significant morbidity and mortality. Treatments include medications, of course. Ablation therapy is very important and very successful. Defibrillators are life-saving, and possibly, and more in the future to come, resynchronization therapy to augment function as well. We know that there's a risk of sudden death, and the decision for an ICD must be tailored to an individual. I would propose that management of these patients should really be a joint process between the cardiologist and the electrophysiologist. And if a patient has not had prior arrhythmias after reaching the end of their childhood and transitioning to adulthood, that they have an electrophysiology consultation if possible for anticipatory guidance so that they know what to watch for and how to pay attention to their body. I'll close by just posting a few of my favorite resources for rhythm management and monitoring in Tetralogy of Fallot and congenital heart disease. Thank you very much.
Thank you so much, Libby. I actually put the link to both the HRS guidelines and Dr. Stout's paper in the chat box while you were speaking. So if people would want to take a look into the chat box, that would be terrific. We've reached the halftime point. I'd like to again re-invite the speakers to open up the Q&A box, all of the speakers, and please take a look at those questions and answer them. I attended a webinar recently, and at the halfway point, the company that put it on had a magician, and it was sort of a great break in the whole thing. And I thought
so you're going to do magic for us, Gil?
Well, I am. I'm going to make this heart disappear. See, it's I can't repeat the magic you guys do in the EP lab or the surgeons do, or Z can do in the cath lab. But I mean, it's just remarkable to see how the progress has gone. And before we move to the poll, Libby, I just did want to ask you one question that relates to a couple of the questions that came in the chat box, which is, we know right now that the older adults with congenital heart disease have a big arrhythmia burden. We've also seen in this talk the change in surgical strategy and transcatheter strategy over the same period of time. Some of those risk factors included Waterston shunts and Potts shunts, with most of the junior faculty and certainly our fellows have never seen before. So I was just going to ask you to speculate, the adult data now are patients operated on in the 80s and 90s. What would you speculate with the newer techniques and the earlier pulmonary valve replacement would be the arrhythmia burden in the current patients about to come into adulthood?
That's a great question. I think that some things will change and some things will stay very much the same. The inherent anatomical changes of Tetralogy of Fallot with the channels of muscle around the VSD will always be a setup for arrhythmias and ventricular arrhythmias in particular down the road. I think with evolving bypass mechanisms, surgical techniques and interventions, the lack of atriotomy and pulmonary valve sparing techniques will reduce a good portion of the ventricular arrhythmia risk, as well as moves for early extubation and the post-operative care as well, I think is really critical to that. Some of the early, we do see electrical changes to the myocardium from the early volume load, that for even in an ASD patient, after you take away the volume load, those changes to the cardiac muscle itself don't change. And so those persist as arrhythmia risks. Part of, I think, our strategy and the change that we're seeing already is the percutaneous pulmonary valve replacement, and moving, having more patients being candidates for that, and we'll continue to do so in the future. I think that does change things in terms of sternotomies and atriotomy and, repeat scars from that perspective. It also needs to change our management a little bit and thinking more proactively about these patients before a transcatheter pulmonary valve. In the OR, the surgeon can create scar lines, or after a surgeon, we can go in through the EP lab and create additional scar lines. Once there's a stent in the outflow tract for a valve, we can no longer get to the muscle under that area to do ablation therapy. So I think we really need to continue to be very proactive in these patients, and think about studying them and having ablations prior to catheter valves as well.
Thanks. It's a very comprehensive answer. And again, I will, also heard from both Dr. Al-Halees and Dr. Sinha, the avoidance of long periods of time of both hypoxemia and volume load from a shunt. I think that's going to make a huge difference. Again, I'm going to recommend that people go to the Q&A box from our team. Dr. Hijazi is going to be talking about exactly what you spoke about. We have some great talks in the second half of this, including Dr. Hijazi talking about the pulmonary valve. We're going to be talking about transition and congenital monitoring. So I think we've set up very nicely for that. I do want to mention sort of one thing about the Congenital Heart Academy that Sasha and Grace and I were talking about, is about the 2021 World Congress of Pediatric Cardiology and Cardiac Surgery. As you may have heard in the introduction, Dr. Al-Halees is the vice president of this international steering committee. We're very excited to host this in the USA for the first time since 1980. And of course, the pandemic has come in. And with the pandemic, two things have happened. We don't know what's going to happen with large meetings in the future. And then the unintended consequence of meetings like this, where over a couple thousand people can get together from the comfort of wherever you are, whether in your home or your office or at work. So we wanted to try to figure out how the potential for virtual meetings might work, and are learning that a hybrid of in-person and virtual meetings is likely the way we're going to go. And as part of the steering committee, I asked Dr. Al-Halees at the beginning of this session where we stand with the World Congress. Things change so quickly. I love the quote that you showed earlier from Maya Angelou. I think Pranava, you showed that one. I'm working with new knowledge now. How is this going to change things? We're learning a lot of new knowledge, not only about tetralogy, but how we're going to hold meetings in the future. And it's certainly interesting to see how all of this has gone, and suggestions. There will be a course evaluation that Grace will talk about in a little bit. It's so important to find out what worked and what we could do better. I'll want everybody to look at. I'm going to just share with you very quickly just something about the World Congress here. I'm going to, hopefully this will open up. Can you see a blank white screen now? Is that right?
Yes.
Yes, we can.
Okay. So I just want to mention just something about the World Congress. Hopefully you're seeing the advertisement for the World Congress. This is going to be a very interdisciplinary meeting. When this started, it was cardiologists and heart surgeons, and clearly our field has expanded, and we've expanded things as well. Let me just get that back up here for a second. There's a couple of really exciting things that I do want to mention. The first is that we are going to have 10 embedded meetings in the World Congress. And I'm particularly excited about the Pediatric Interventional Cardiology Society meeting, the PICS meeting that is so internationally known that Dr. Hijazi has run. We will have PICS at the World Congress. So there will be the same live cases, the same excellent stuff that people have seen at the World Congress, at the PICS meeting in the past as part of the World Congress. And it's great to have you here, Ziyad, as part of this program.
Thanks.
Good to see you, man. The World Society of the World Society for Pediatric and Congenital Cardiac Surgery will be embedded. The Pediatric Cardiac Intensive Care Society, the Fetal Heart Society, the International Society for Mechanical Circulatory Support, International Society for ACHD, all of those and many more, all of those 2021 meetings will be embedded within this World Congress with the science decided by the individual societies. We're hoping for an in-person meeting. We have something along the lines of 12 or 1,300 individual talks, great breakouts as well as plenary sessions. And then finally, what's new this year is, and I'm looking this way because I want to be sure to get it correct, is we will be having a featured international village for the international societies. So there'll be 7 international societies presenting the best from their work, including the Asia Pacific Pediatric Cardiac Society, the AEPC, or the Association of European Pediatric Cardiologists, the Cardiac Society of Australia and New Zealand, the Pan-African Society of Cardiology, the Pan-Arab Congenital Heart Disease Association, or PACHTA, the Pediatric Cardiac Society of India, and I know that we have a lot of people from those societies on this call, so I just wanted to give a shout out to them. And then I hope I say this right for my Spanish-speaking friends, the Sociedad Latina de Cardiología y Cirugía Cardiovascular Pediatrica, or the Latin American Pediatric Cardiology Society. That's about as best as I could do with that. So I hope people take a little stretch before we get into the second half of this, and I'm going to turn this over to Grace.
Thank you, Gil, and thank you all the speakers for the amazing talk so far. We are going to have much more after this short break. I'm going to share my screen with you because I have some announcements, and then we are going to have some questions and discussion before we start the second half of this meeting. Well, once more, welcome everybody to Congenital Heart Academy. We're really happy to have this meeting in association with the Saudi Heart Association. We are really happy with this. And please follow us on social media and talk to us in all possible channels. And specifically, we have all our meetings uploaded on YouTube. So you go to Congenital Heart Academy YouTube channel, and you're going to be able to see all of our previous talks there. And whenever you want, this is going to be great. And if you want to talk to us, please send us an email. And to get every time better, we really want to listen what you have to tell us about this specific meeting. So please take some minutes. It's just a 3-4 minute survey to talk about how do you feel about this meeting. This is the link. We are going to place all of these links on the chat box, and we are going to send you by email as well. And I just have to, I want to announce to you our next activities. So this Friday, as also known as tomorrow, we are going to have a very special talk from Dr. Robert Anderson about sequential segmental analysis of congenital heart defects. It's a morphological meeting that we have every Friday. On Saudi Arabia time, it's 4 p.m. and 3 p.m. European time. And we have next Monday, Dr. Meryl Cohen talking about the echocardiography features of double outlet right ventricle. It's going to be very nice. The AV canal first talk that she gave was very interactive, a lot of discussion. It was very nice. I hope you all can join us. So next Monday, 1 p.m. East, 7 p.m. Europe, or 8 p.m. Saudi Arabian time. And on the 3rd of August, we are going to have Dr. Silverman making the correlation between imaging and morphology. He's going to talk about Tetralogy of Fallot on this first one of his series. And then we are going to have, so next Thursday, we are on vacation. And the next Thursday, on the 6th of August, we are going to have a masterclass of electrophysiology. We are going to talk about sudden death and arrhythmias. We hope all of you can participate on these activities. Something very nice that we were able, with very kindly that Gil and Dr. Anderson were able to provide to all of us, is a 35% discount on the Dr. Anderson book, whose Gil is the editor-in-chief. So if you go to the Elsevier website, you can enter the discount code Anderson35, and you're going to get 35% of discount on this book. So that's what I had to show you for now. I hope you are all enjoying, and now we are going to have our pool. And first of all, we want to know what you have to tell us. Can we go to the first pool, please? Yeah, so we want to know, you have 2 questions on this one. Please see that you have to screw the pool. So we want to know, where are you from and what is your specialty? Please answer to us.
Just to remind everybody, you will need to scroll up and down to answer both questions.
When we have around 50% of people answer, we can stop the pool and show the answers, please. I think we are okay. We can stop the pool. Let's see where people are from. So we have the majority of people from Middle East. Thank you, Saudi Heart Association, for that. And most of people are pediatric cardiologists, and we are very happy to see nurses well represented and allied health well represented as well. We are very, very happy for that. This is important to say that Congenital Heart Academy is for all the multidisciplinary team, not only for physicians. We are really happy for that. Okay, now we have some questions from our previous speakers that's going to open for a short discussion. The first questions from Dr. Al-Halees. Can we launch that pool? Okay. Do you want to read your question for the attendees?
I cannot see the question on my screen.
Okay, so I can read them and then people can vote. So a 4-month-old infant presented with history of repeated cyanotic spells. Evaluation reveals tetralogy of Fallot with good sized pulmonary arteries and a borderline sized pulmonary valve annulus. The LAD is crossing the right ventricular outflow tract just below. I can see the rest of the question. I think probably is the asking up what is the best procedure for this patient.
Sorry, the question is, A is a palliation by BT shunt, reloctaucid. Second option is a balloon dilatation of the pulmonary valve plus minus stenting of RBOT. The third is correction with right ventricle to pulmonary artery conduit. The fourth is transatrial correction, accepting a residual gradient. The last one is conservative and start on Inderal and home oxygen to delay operation to an older age.
You can all vote, please.
Gil, sorry, we have a problem because I saw on the chat that we have an orthopedic surgeon that cannot leave this meeting. So I'm very scared about the answer from him about it. So I'm very happy. This is amazing.
I'm quite sure that the answer to do an operation will come from the surgeons. The answer to do a balloon dilation will come from the interventional cardiologist. And the answer for medical management will come from people like me and Grace. No, that's not true. I'm just curious what people have to say. But okay. I see Pranava and Zohair both nodding their heads about which of the surgical options they'd like to do.
I think it's okay. You can stop the pool and show the answers. Okay, can you comment on that? So 33% said we should do a correction with right ventricular to pulmonary artery conduit.
Zohair, you want to do that one, please?
Again, I don't see the screen for whatever reason, but I think I expected that people would say that the least answer would be the conservative with home oxygen and enderal. Was that what the poll showed?
That's what it was, yep. Correct. That's certainly different than 30 years ago, right?
Correct, absolutely, yeah.
Ziyad, do you want to comment on balloon dilation and stenting? Or are you going to talk about that in your talk?
No, I can make a comment now. I think, in such kits, because if you're going to put a conduit now, that you're going to, change it down the road, and depending on how fast the child grows. So an option is to do balloon dilation and stent implantation if you can preserve the pulmonic valve. If you cannot preserve the pulmonic valve, then I think I agree with Zohair, probably a conduit will be the better option in this patient.
Thank you. Any other comments from the panel?
I think we need to define what borderline pulmonary annulus means. I think that borderline means it could go either way. I would certainly go ahead and repair this child without a conduit unless the valve is completely dysplastic. In which case you could still do a repair by putting a patch above and below the LAD. Like I mentioned in my talk, I think that the RVOT is more complicated than just the pulmonary valve annulus. It is a multi-level obstruction. So R1 plus R2 plus R3 are in series. And as many resistors you can eliminate, it's going to be better for the patient. Unless your pulmonary valve annulus is completely hypoplastic, you would probably get a pretty reasonable result with a complete repair, even in borderline cases.
Occasionally, what we have done also is mobilize particularly if the LAD is very superficial, you can mobilize the LAD at both ends and actually cut below the LAD and have the LAD sit on top of the patch. And that occasionally can work.
Okay, thank you. Now we have 2 questions from Dr. Laura. Can we launch that poll? Okay, Laura, can you read for the audience?
Sure, I have very straightforward questions, but the first one is, how is the Tetralogy of Fallot right ventricle different from the normal right ventricle? Option A is it's not. The RV in TOF is the same as the RV in normal hearts. Option B is the RV in TOF has a well-developed myocardial middle layer, which is not seen in the normal RV. Option C is the RV in TOF contracts mostly in the longitudinal plane after surgery. And option D is the RV in TOF only remodels after TOF repair.
Let's see what people think about it. And talking about it, Dr. Anderson gave an amazing talk about morphology of Tetralogy of Fallot. It's in our YouTube channel. And if you, as all of you are interested in this subject, in this topic, please take a look. It's a 1-hour talk that it was really, really amazing. We learned a lot from him. Okay, I think we can stop the poll and show the results.
Yeah, that's great. People were paying attention. And speaking of Dr. Anderson, this is actually from his publication.
Amazing. Okay, we have one more question from Laura.
When addressing the right ventricular function after tetralogy repair, the best parameter is TAPSE because it is easy to obtain. RV global longitudinal strain or free wall strain because it is a sensitive parameter of systolic function. TAPSE again because it's the most accurate. Fractional area change because it's easy to trace the endocardial surface of the RV. And eyeballing is enough, and that's what we should use.
You brought a lot of new information, I'm sure, for a lot of people. So let's see what they are going to answer based on the new information that you brought, the new knowledge that you brought to all of us. Okay, I think we can stop the pool and show the results.
There we go. So I want to actually make a disclaimer about TAPSE. I love TAPSE. I just think that we have to know when to use it. So it's great for pulmonary hypertension or for unoperated hearts. So other disease states like pediatric ARDS, any situation where you have a concern for RV function in a heart that's not remodeled, like tetralogy, which is abnormal or different even before surgery. So TAPSE is very good to assess the longitudinal function. So when I report on it, I'll say indicating preserved or abnormal longitudinal contraction of the RV. I'm very clear about the information I'm giving when I'm using TAPSE, but definitely very easy to obtain.
Okay, we have a lot of interesting questions on the Q&A chat, and it would be great if we were able to discuss all of them live, but for the sake of time, we have to move forward for our next speaker. So we are going to continue to answer your questions on the Q&A chat box. You can type there, and we are going to do our best to answer all of you. So now our next speaker is going to talk about when and how should the pulmonary valve be replaced. Is Dr. Ziyad Hijazi, is Professor of Pediatrics and Medicine at Weill Cornell Medicine, the CMO of Sidra Medicine, and Director of the our Heart Center, and Editor-in-Chief of Journal of Structural Heart Disease, and Honorary Professor at University of Jordan, and my boss. Dr. Z, welcome.
Thank you, Grace. Do you guys see my screen or not?
We do see, but you need to go to presentation mode.
Do you see it now?
Seems that it's coming. Yeah, it's perfect.
Okay. Good morning, good afternoon, good evening, wherever you are, guys, in the world. And first, I would like to thank the Congenital Heart Disease Academy for inviting me to talk. Also, Gil, I hope next year is going to be in person. I don't want any more virtual. We're virtual out. So I hope that next year it will be definitely in person in Washington, D.C. Even if it's not in person, I'm going to be there in person. This is my disclosure slide. All right, so the learning objectives from this talk, certainly they are in front of you here. So we want to make sure that, let me just take this other screen out. All right. These are the learning objectives for this talk. I
can't see your talk anymore, Dr. Z.
You can't see it anymore?
No.
Really?
Yeah.
Oh, gosh.
But you look good.
Thank you.
And the background is very beautiful. Doha is an amazing city.
Yeah. Let me see if this will come back now or not. Do you see it now?
Not yet. You need to share your screen again.
Huh. Okay, share screen. Do you see it?
Yeah, perfect. Just need the presentation mode.
Okay, so let me just move this thing here. All right. So we all saw the beautiful talk earlier by Dr. Rosa about how to assess pulmonary insufficiency in these patients, because this is the most important thing, that because you want to know the degree of pulmonary insufficiency that these patients have. And we saw that primarily we depend on echo, but there are other modalities. So usually start with the physical examination. We know that it is not very accurate, but you can tell if there is a significant diastolic murmur. EKG may be helpful. You need to look primarily at the QRS duration, and in our practice, if any QRS duration longer than 180 milliseconds, that's usually associated with some ventricular ectopy or arrhythmias. Then echocardiography, and again, you saw the talk that Dr. Rosa did. You can see the color Doppler flow, the pulse Doppler, and also what I look at the pulsatility of the right pulmonary artery in these patients. Cardiac CT is important for many reasons. You can look at the landing zone where you want to place a valve. You need to look at the proximity of the coronary arteries from the outflow tract, because this is an important issue that we need to address in these patients. Then you move to the cardiac MRI, which is probably the most useful imaging modality in getting objective parameters. You need to get the right ventricle in diastolic volume. You need to get the right ventricle ejection fraction. You need to get the right, the pulmonary regurgitant fraction, and also we look at the right ventricle end systolic volume. All these are important, and when we discuss the guidelines, they primarily depend on these numbers. Then finally, of course, cardiac catheterization. I would not take a patient to the cardiac cath lab unless I'm pretty sure that I need to assess and I need to implant a valve. However, because of the unavailability of valves on the shelf, I justify doing a diagnostic cardiac cath with balloon sizing, with also assessing the proximity of the coronary arteries to the outflow tract. Then once I know that for sure, I can tell the family, yes, a valve can be implanted safely there. And then of course I can ask the manufacturer about what size valve I need. Because as I said, these valves are very expensive, and to have them available on the shelf in every lab is difficult. So you do a diagnostic cath, assess the size that you want, the proximity of the coronary arteries, the landing zone, and then go from there. We discussed all of this. These are the images that you look with the echocardiography. The area of the right ventricle on 2D echo is not accurate, but if you use it in the same patient for follow-up, then it can be accurate. And again, this is the Doppler showing you the abrupt diastolic fall in the retrograde flow in the pulmonary artery, indicating that this is severe pulmonary insufficiency. And this is what I mean by right pulmonary artery pulsatility index. You look at the RPA size in systole, diastole, and then you assess the ratio. And this is the right ventricle area. This is the CT scan. Again, I mentioned you look at the landing zone, the coronary arteries, and whether there are other associated problems with the branch pulmonary arteries, because the last thing that you want to put a valve in the presence of distal branch pulmonary artery stenosis. So you need to make sure that you assess that before you go. And then this is, of course, last is the MRI, looking at your right ventricle size, as well as the ejection fraction, regurgitant fraction, and any other associated lesions. Cardiac output, cardiac cath, you can see it here, looking at everything, the traces, the right ventricular pressure, whether there's significant obstruction or not, and you, of course, compare that to the systemic pressure, and you can look at angiography in the right ventricle, main pulmonary artery, and the branches. All right. Then, once you determine that, okay, this patient meets the criteria for valve placement, obviously there are two major methods: the open heart surgery that Dr. Al-Halees and Dr. Sinha touched on, and then of course transcatheter. Now the transcatheter, before the transcatheter, going to the surgical techniques, there are different ways. If you want to do it, the transannular patch or the valve sparing technique. But if the patient requires a valve after what the surgeon did their primary operation, they can do it using one of these, one of three things: either a homograft or a cloth tube or the Contegra. It is rare, and I can ask Zohair and Dr. Sinha that the surgeon use a prosthetic valve in the right side of the circulation. Nonetheless, surgery does carry with it some morbidity and mortality. The lifespan of a xenograft is about 10 years, homograft 16 years, but we all know, and the surgeons can attest to that, in reality, that it is not uncommon to have patients needing replacement of these xenografts or homografts after much shorter time period than what is in the on the slide here. Each operation has morbidity and mortality, and again, it's here 4% for the initial operation, and it goes to 13% mortality in the fourth operation for different reasons. And I always cite this paper published by Jim Twiddle in Circulation, looking at 100 patients who received the homograft. As you can see, at about 4 to 5 years, about 25% of the patients already had re-intervention. And if you look in the red text, about half of the patients had homograft dysfunction. So we all know in reality, many of these patients who receive homograft, it does not last that long. So indications to replace the pulmonic valve, and again, this was touched on earlier, the paper published by Stout and her colleagues in 2018, they looked at all the criteria as to when to replace the pulmonic valve. Obviously, if the patient has symptoms with severe PR, nobody would argue that these patients will require a valve. The problem, many of these patients are asymptomatic, then you need to look at objective parameters, and those are obtained by the MRI. So we look at right ventricle end diastolic volume greater than 150 to 160 ml per meter square, or in systolic volume greater than 80 to 85 ml per meter square, with regurgitant fraction more than 35 to 40%, that's important, and if the right ventricle ejection fraction is less than 40 to 45%. When I have a patient like this, I can comfortably proceed with pulmonary valve replacement. So the currently approved valves in the market in the US or outside the US, two valves, the Melody valve and the Edwards valve. So let's discuss where these valves are applicable. Obviously, the Melody and the Edwards valve are good for patients who have either a homograft or a bioprosthetic valve. It is uncommon that we use either valve for patients who underwent a transannular patch, because these valves were manufactured to place in patients where there is a landing zone. We put a stent or a homograft and it's dysfunctional, you stent it, then you put the Melody or the Edwards valve. Unfortunately, the percentage of patients who meet such two valves is approximately 25 to no more than 30%. This leaves about 70% of the patients where these two valves, they do not meet the needs of these patients. But right now, the Melody and the Edwards, I would say they are good enough for approximately 20 to 25, maybe 30% of the patients. And the list on the slide here shows you that the types of conditions, truncus arteriosus, pulmonary arteria VSD, and any patient who really had a conduit between the right ventricle and the pulmonary artery. This is the Melody valve. Again, I want to acknowledge the pioneering work done by my colleague, Philip Bonhoeffer, who pioneered all of this. He was the first one in the world, actually, to place a transcatheter valve, period. And in this case, of course, it was a pulmonic valve, but it was even before TAVI era. And what he did, Philippe went to the slaughterhouse, harvested the jugular veins of many cows, came and sutured that into a Cheatham platinum stent. Then he was able to crimp it on a balloon catheter, and he was able to deliver that initially in sheep, and then, of course, in 2000 in humans. So again, this natural bovine jugular vein valve, available in sizes from 16 to 22 millimeter, although some of my colleagues used it to 24 millimeter with some mild regurgitation, but the recommendation is 18 to 22 millimeter. The stent is made from platinum, 90%, iridium 10% frame. The length of the stent is 28 millimeter, and the crimping profile is 6 millimeter on a bib balloon in balloon catheter. Again, so this is the stent is very radio opaque with a lot of integrity with gold welding between the struts of the stents. This is the delivery system. The advantage of this delivery system that it is covering the valve all the way until you get to the target lesion. Unlike the Edwards, once you exit the short 35 centimeter delivery sheath in the IVC, it is exposed. So if you cannot get to the target lesion, basically you are in somewhat trouble. But the Melody valve is covered all the way until you reach the target lesion. So again, this is the Melody valve. This is the ensemble delivery system. And again, Melody ensemble because Philip, as we many of you know, he is an avid and almost professional violinist. So he called the valve the Melody and the delivery system the ensemble. This slide shows you the timeline, the historical dates when the valve was used. So the first implant in a human was in France in 2000, and then the valve received approval in the US under HDE guidance in 2010, and in 2015 the valve received approval in the United States for pre-market approval. The valve is being used all over the world, but primarily majority of the implants, 55% in the United States, 35% in Europe, and in the rest of the world is 10%. And this is simply because of the high cost of the valve. It's very expensive at about $25,000 to $30,000. The valve had many studies published to prove that it is safe and good. You know, we have the US trials, the UK experience, German, Italian, and so on and so forth. Majority of the diagnosis, 45% Tetralogy of Fallot patients with a conduit, but there are other diagnoses, you know, patients with status post operation and other diagnoses. The valve has good longevity, up to about 8-9 years, about 79% of the patients free from re-intervention using the Melody valve. Again, this is a similar slide to the previous slide. At baseline, the New York Heart Association, many of these patients had a New York Heart Classification Class 1 and the Class 2, and after they received the valve, they improved from symptoms point of view. This is an example of a patient that I did received basically a conduit in France. This conduit became dysfunctional shortly after surgery, and you can see how calcified. So this is the first angio. When I saw this, I sent the patient to the surgeon to take care of this calcified conduit to repair the branch PS. The surgeon put a bioprosthetic valve in this patient. There's the valve, but you can see that the branches are dysfunctional. And the origin of the branches is not good. So I had to do what we call kissing technique, put 2 stents there, decrease the RV pressure. And then a few months later, he comes back with more stenosis and the RV pressure increased. So I had to dilate more and more. The bottom line, after multiple procedures and significant PR and large right ventricle, and you can see the right ventricle in diastolic volume is 239 ml per meter square, RV ejection fraction is reduced, and the regurgitation fraction is 31%, I had to place a valve in this patient. So I took him again, dilated, and put the Melody valve with some difficulty, but nonetheless, we were able to place it and preserve the competency of this valve here. And now, actually, I've been following this patient since 2013 with excellent result. His RV pressure is about 55% systemic. So in summary, for the Melody valve, high success rate, low rates of device-related adverse events. The gradient remains low, and improved functional capacity. Freedom from catheter-based reintervention is just about 80% or more. The only caveat of this Melody valve is the incidence of endocarditis. So this is an important point that we need to remember. Endocarditis is about depending on what article you read, between 2.5 to 3%, in some studies up to about 9% in these patients. So that's one thing. The other thing that I did not mention, when you place the Melody valve as well as the Edwards valve, which I mentioned earlier, is accurate assessment of the proximity of the coronary arteries to the right ventricular outflow tract. In 5 to 6% of the patients, the distance between the coronary artery and the RVOT is so close so that with balloon dilation, to test that, you have coronary artery compression. Obviously, if you put a stent there, that would be catastrophic. So these patients should be excluded from percutaneous valves, and you send them to our surgical colleagues. The second valve is the Edwards valve. It's made of 3 bovine pericardial leaflets. It's the stent is cobalt chromium, diameter anywhere from 20 millimeter now all the way to 29 millimeter, delivery sheet 16 to 21 French in diameter. We did in the US the compassion trial to test the feasibility and safety of this valve, which we proved that, and then the valve received FDA approval. So the trial was prospective, non-randomized trial using the Sapien valve, the old version. Now we have, of course, Sapien XT, and we have the Sapien 3. They underwent a trial. The Sapien 3 just underwent a trial for this, and I believe the valve is being approved as we speak. So the primary outcome, freedom from device failure, secondary outcome, freedom from MACE, and evidence of functional improvement in regurgitation, as well as in New York Heart Classification. This is just basically an example of a patient who had a large homograft that is dysfunctional. You can see assessment of the coronary arteries, make sure that they are far. Then in both the Edwards as well as the Melody, you need to place a landing zone, bare metal stent. The Edwards, not because to prevent a stent fracture. In the Melody valve, we did that to prevent a stent fracture of the valve, which was present in about 30% of the patients. The Edwards valve, we place it because the valve itself is short. So we need a longer landing zone. So for your accuracy does not have to be up to the millimeter, it's less. So in this case, we place the bare metal stent, and then you can see that it looks good. And then if I scroll here, then you place the valve in the middle of the landing zone, and then you basically can touch it up with a balloon. And then final angiogram, you can see there, the angiogram looks good. There's no pulmonary insufficiency. So it's really a great valve to work with. And at the end, you assess, of course, again, the coronary arteries and everything. So the summary for the Edwards valve, 98% freedom from device or procedure-related death, 97% freedom from MACE at 6 months and 1 year, 100% freedom from stent fracture because the stent valve is short, 90% freedom from endocarditis at 1 year, 95% improvement at least by 1 class in their New York Heart Classification, and of course, 100% improvement at least 1 grade in the pulmonary insufficiency. Because by default, many of them, once you place the bare metal stent, you stent open whatever functional valve there. And again, these patients improve. Complications, this is extremely important. Stent fracture, this is valid for the Melody, but not for the Edwards. Coronary impingement, and that's why you have to assess the coronary artery proximity. Device embolization does happen. Fortunately, it's less than 5%. Paravalvular leak is very rare. Homograft rupture and dissection, and that's why I want to emphasize that any lab engages in transcatheter pulmonary valve replacement, you have to have available to you on the shelf covered stents to bail you out from this complication, and you have to have surgical coverage in-house should you be not able to bail these patients using catheter techniques. Infective endocarditis, it affects both the Melody and the Edwards valve, but the Melody valve definitely is more than the Edwards valve, and of course, rarely death. Now, moving to the other side of the slide, on the our left-hand side, again, as I said earlier, the Melody and the Edwards, they cater towards 25, maybe 30%. This leaves 70% of the patients that are unhelped. Those patients, these valves now, they're not approved, they're being investigational, the venous P valve, the Medtronic Harmony valve, the Pulsed valve, and the Beijing PT valve. All 4 valves are good for patients who underwent what we call transannular, or what we call it native. It's not really native, it's post transannular patch repair. How do we assess the suitability of these patients? You know, of course, echo, CT, MRI, 3D prints. The bottom line, you need to do, after you do all these tests, balloon sizing for these patients. And I'll show you this in 1 second. So this is, for example, the 3D. When you look at a 3D model like this, you can say, and you do the measurements, as long as the diameter is less than 34 millimeter in diameter, you can say, I'm confident I can place, for example, the venous or the Harmony valve or the other 2 valves. So you do cardiac catheterization. So in this patients, you do the angiogram, you can see large outflow tract, post-transannular patch. So this is the first angio. Then you will do balloon sizing. So 2 catheters, one in the RV and one in the MPA. You inject in the RV while you are occluding the MPA. Once you know that there is no dye that goes to the branches, then you can say that this is the size. You freeze the image and you measure the size of the balloon, and that will give you the size of the valve that you want to use. Then, of course, you need to assess the coronary arteries either by root injection or selective. In this case, we did root injection, and you can see the coronary arteries, they fill nicely, so you know that you are far from the coronary arteries. And then, of course, you can say, well, I can place the valve. Let's talk about the venous P valve, made of nitinol, self-expandable, and the valve leaflets are made of porcine pericardial tissue, and the valve itself is covered except the distal 10 millimeter, where we will place the distal 10 millimeter at the origin of the LPA and the RPA, so that you will be able to access these branches. So this is an image of the valve. You can see the distal 10 millimeter are not covered by the porcine pericardial tissue. And by the way, the valve is available in sizes from 16 millimeter. And when I say 16, it's the diameter of the middle waist, 16. And the length, also the length of the straight portion of the valve. Therefore, the uncovered is 10 millimeter longer, and the flared proximal portion is another 10 millimeter long. So it's 20 millimeter longer than the middle segment. This is delivery system. I don't want to waste more time on this. It's basically self-expandable. You need to crimp it in frozen or very cold saline so that the nitinol forgets its memory. And then once you put it in the human body, exposed to body temperature, it remembers the shape that the manufacturer made it in it, which is the shape that I showed you. This is the valve is ready. Then you go there. We did the first in human, actually, in 2013, May 24th, 2013. So now we have about 7 years of experience in the first 2 patients. This is, sorry for that. This is the first patient that I did in Shanghai. She is still alive and doing very well, and the valve actually is functional very well. We did the angiogram. You can see the MPA on the lateral frontal. I'll scroll there. There is balloon sizing. There is coronary angiography, far, and then we take the valve, and self-expandable. So you have all the time, release slowly, do control angiography until you are 100% sure that you are in the right position, until you completely release the valve, and you can see final assessment, no insufficiency at all, and the patient has done very well. This is with intracardiac echo. After the placement, there's no need to do intracardiac echo, but you can do transthoracic echo or intracardiac or TE, but there's no need for that at all. And the patient did. This is another patient that had severe PR. She underwent a transannular patch, as you can see here. So her right ventricle in diastolic volume 167 ml, ejection fraction 36, regurgitation fraction 44%, and her hemodynamics were basically fine. And then you assess, as I mentioned to you, and then there is the balloon sizing. So to me, this is the most important step, to choose the size of the valve. And that's what I said. I usually do diagnostic cath in these patients so that I can tell the manufacturer, bring me size such and such. and then you do the RV angiogram. This one 30 millimeter by 25 length, and then you basically do all of this, and then your final angiogram. It looks very good and no pulmonary obstruction. So really the valve is user-friendly. And so the venous P valve underwent a Chinese trial, a CE European trial, and a humanitarian use. The Chinese trial, 55 patients, they all did very well. The CE trial, we finished, we did 83 patients. Shaq Qureshi was the PI, I'm the global PI. He's the PI for the trial in Europe, as well as in Qatar and Brazil and Taiwan, along with European countries, Germany, Belgium, and Italy. These are the countries that the valve has been used in the humanitarian use criteria, many countries. The other valve is the Harmony valve by Medtronic. The US trial is underway. Few patients have been implanted so far using the second valve size. Many patients, 25 patients, use the 22 millimeter size, but they found that they need larger sizes, so they made the 25 millimeter, and now the valve is being tested in the US with very good early results. So to conclude, both Melody and Sapien valves are available for transcatheter. Both cover about maybe 30%. The other valves will cover the rest. Results of the Melody and the Edwards are very good. And now for the native outflow tract, we have the Venus, we have the Harmony, we have the Pulsar, and we have the Beijing valve. And I'll stop here, and I hope that you will join us September 11 to the 13 with online, with live cases during PICS. Thank you so much.
Thank you very much. Every time, Dr. Zimek, this is very easy to do, but we know very well that how is complex, and we are very happy as we are third generation pediatric cardiac surgeon. We are learning from your first generation interventional cardiology, and working with a beating heart is every time something special. So you see soon what you are doing. We need to wait that the heart start again. So your job is amazing, and compliments. You don't need my compliments, but it's fantastic. So then we move from one word to another word. Is the word of Dr. Eva Goossens, who is a special researcher, because this child that has operated and grow up, and the problem or the strategy to move to a transitional program, it's very important. Professor Eva Goossens took his degree in Leuven. Then he moved to McGill University in Sweden at the Gothenburg University. Of course, he has a particular interest in epidemiology, healthcare service, and cardiovascular nursing. And she's currently appointed as assistant professor at the Center for Research and Innovation in Care at the University of Belgium of Antwerp. The lecture will be about developing a transition program for adolescents with Tetralogy of Fallot and other complex congenital heart disease. So we give
Thanks, Sasha. Eva was kind enough to, Eva was on vacation or holiday, and she was kind enough to send me her 20-minute presentation, which I'll load up in just a second. And also to let everybody know there, after this talk, there will be one more excellent talk on the planning strategies of young adults with tetralogy. So thank you all for staying so long for this wonderful webinar. And I will load, I believe, let me know, Sasha, if this video is now showing.
Yes.
Let me know if you hear the sound.
Hello.
Yes.
Welcome to the online presentation. My name is Eva Goossens, and I was invited to give this presentation about developing a transition program for adolescents who are affected by complex congenital heart disease, like, for example, Tetralogy of Fallot. I have no conflict of interest to declare for this talk. Today, we can say that all congenital heart diseases, even the most complex ones, can be treated successfully. Survival of patients with congenital heart disease has dramatically improved over the last 6 decades. Indeed, survival at 18 years increased from 25% in the 1950s to over 90% nowadays. This has been the result of the continuous improvement of surgical and percutaneous procedures, of pediatric cardiac anesthesiology, including extracorporeal support techniques, intensive care, and prenatal diagnosis. There's a list of innovations in CHD care that emerged over the past 40 years. These innovations have had the most positive effects on patient outcomes. Successful neonatal and infant cardiac surgery have led to increased survival prospects for young children, especially for infants with low birth weight or highly complex defects, which were associated with high mortality rates in the first days of life. Remarkable gains in survival prospects were observed. Furthermore, improvement developments in the domain of interventional cardiac catheterization that initially started as primarily diagnostic procedures, but nowadays are most often performed as interventional procedures, were of major significance as these treatment options replaced open heart surgery for many children with congenital heart disease. A lot of imaging techniques were developed over time, such as fetal echocardiography and MRI. These techniques resulted in prenatal identification of CHD, which in turn has led to early warning and the opportunity to change the obstetrical management of the mother and urgent care of the neonate, resulting in optimizing care and early diagnosis. But also the development of drugs such as newer inotropes useful in pediatric ICUs, mother and diuretics, beta blockers for several new indications, the development of prostaglandins in the management of neonates, etc., were important to achieve better patient outcomes. And finally, one of the most important developments in CHD management is the work being done in the domain of genetics. Being able to understand the genomic basis of some heart defects has redefined treatment and preventive measurements, such as the discovery of the long QT syndrome. Thanks to these improvement advancements in medicine and nursing care, the survival rates for children born with congenital heart disease increased markedly over the past decades. As today, about 90 to 95% of children born with a congenital heart lesion reach adult age, the number of adolescents, adults, young adults, and more senior adults affected with CHD is growing rapidly. Survival through childhood is now common, even in the most complex and lethal malformations, such as Tetralogy of Fallot. As demonstrated by a Canadian population-based study on the prevalence of CHD at population level, the number of adults with CHD was found to be outnumbering the number of children affected by this condition. Based on these analyses, we've learned that for every child born with CHD, we nowadays have 2 adults to care for in our healthcare system. While the relative risk of mortality during infant life remains substantially higher than for healthy persons of similar age, the risk is nevertheless low when expressed in absolute terms. These changes in survival prospects will rapidly increase the number of young adults, but also senior elderly and elderly with congenital heart disease. This demographic change brings along an important challenge for our current healthcare system. As the dramatic early benefits of cardiac intervention and surgical repair in childhood have become routine, the sequelae of CHD and its treatments have increasingly emerged in adulthood. As a consequence, the care provided to adults with congenital heart disease should differ from the care provided to children and adolescents in pediatric cardiology. This because we see that the healthcare needs that are addressed or should be addressed in adults with CHD differ substantially from those that are expressed by children and young adults. Despite the significant decline in mortality observed in this population, patients have a lifetime risk for deterioration of their health condition due to the progressive valvular and myocardial pathology and emerging complications. It is estimated that more than 50% of adults with CHD are at a medium to high risk for complications such as heart failure, infective endocarditis, pulmonary hypertension, the development of arrhythmias, sudden cardiac death, etc. Therefore, experts recommended that in order to prevent, manage, but also treat these complications, patients should receive uninterrupted cardiac follow-up care throughout their life. Lifelong specialized care therefore becomes of paramount importance to safeguard longevity and prevent life-threatening complications. During childhood, care is provided at pediatric cardiology programs. As patients grow older, navigate adolescence, and approach adulthood, the majority is ready to gain independence and manage their medical condition independently from their parents. This is a subtle change in care participation and care needs. This process of development often accumulates with a change of the healthcare setting as well. When reaching adulthood and during a period of medical stability, young patients are often advised to transfer the care from the pediatric care facility towards a more adult-focused setting. Such a transfer of care from pediatric cardiology towards an adult specialized CHD care program should guarantee that patients are cared for in an environment that addresses their medical and psychosocial needs. Patients diagnosed with a complex heart lesion, such as a transposition of the great arteries, or for example, Tetralogy of Fallot, should require ongoing cardiac care exclusively provided at specialized regional ACHD centers every 6 to 12 months, according to the guidelines. However, when we look into the literature, we found that in a majority of young adult patients, we see that this transfer from pediatric to adult care is not going too well. When we perform a quick scan of published papers, we learn that a large majority of adolescents are lost to follow-up when transferring from pediatric cardiology towards an ACHD care facility. These care gaps actually have been found to have a significant impact on the health and the quality of care that we provide to adolescents. As previous studies have indicated, that care gaps increase the risk of developing symptoms and needing a very urgent intervention, increased by a threefold. But you might wonder what we talk about when we use the terms transfer and transition. Therefore, I would like to address just simple definitions for these two concepts to show you how they are related, but also should be considered separately from one another. Transfer and transition are two interrelated, though distinguishable concepts that are often, incorrectly, used as synonyms for one another. The inconsistent use of these concepts might originate from the current lack of a uniform standardized definition. When reviewing the current body of literature, one finds a wide variety of definitions for transfer and transition. Clear definition of these concepts is, however, quite important. Transfer has been defined as an event or a series of events through which adolescents and young adults with chronic physical and medical conditions move their care from a pediatric to an adult healthcare environment. The transfer of care includes a relocation of care from a pediatric to adult-oriented healthcare setting as a means to guarantee that patients receive continuous care as they age. But since the healthcare needs of patients with CHD evolve over time, an adaptation of the healthcare environment is mandatory but should be aimed for in a gradual approach. Transitional care for young people affected with a chronic condition such as CHD focuses primarily on the developmental transition that is experienced by young people with and without a chronic condition. Transition is therefore defined as a process, a growth path, by which adolescents and young adults with a chronic childhood illness are prepared to take charge of their lives and their health in adulthood. There is a general consensus that an abrupt, unprepared transfer toward adult care should be avoided at maximum. Patients should receive guidance, support, counsel, enabling them to gradually prepare themselves for the responsibilities, tasks, and expectations to be fulfilled in adult life and healthcare. A transfer of care of adolescents from pediatric cardiology towards adult CHD care primarily aims to safeguard continuity of care as patients grow older. Such continuity of care is considered vital to prevent complications, detect a progressive decline in functional status, and to provide state-of-the-art patient management. As indicated before, a significant proportion of patients is, however, found to have care gaps. Such discontinuation of care is furthermore found to start at quite a young age. This figure was derived from one of the studies performed by Andrew Mackey, who performed a province-wide study investigating a cohort of children who were diagnosed before the age of 6 years with CHD and who were still alive at the age of 22 years. Based on this figure, we've learned that over time, as young patients are growing older and entering adolescence and young adulthood, the attrition from cardiac follow-up is increasing rapidly. As indicated, in the group of patients that were aged 18 to 22 years, the attrition rate actually resulted in about 4 out of 10 patients who were still seen by a cardiologist, meaning that 6 out of 10 patients were lost to follow-up. When talking about the need to transfer patients with CHD from pediatric cardiology towards adult-focused facilities, one could question if we should care about this transfer. What can be the expected effect of such a transfer? And is it really vital to transfer adolescents with CHD towards adult specialized CHD care? The research group of Mailotti was one of the first who published a study to presented good evidence for a survival advantage to ACHD patients being cared for by an ACHD cardiologist. The study was a province-wide administrative longitudinal database with data ranging from 1990 up till 2005, combining both a sequence of time series and case control analysis. Mailotti concluded, based on these study results, that specialized ACHD care was associated with reduced mortality. Patients with more complex CHD, like patients with Tetralogy of Fallot, who have a higher expected mortality rate, benefited more than the patients with less severe forms of CHD, but all groups showed a reduced mortality. Although some of the previous elements addressed could convince us that it is important to organize transfer of care and to develop transition programs to prepare patients and their parents for such a vital change in the healthcare provision, the question still remains how to develop a transition program for young patients affected by a complex heart lesion. Numerous guidelines, consensus statements, and position papers have been published over the past decade, describing the rationale, objectives, importance, and main principles of the development, the implementation, but also the evaluation of programs. Based on the overall objective, a transition program should focus on a set of aspects. First of all, skill development. Secondly, self-management attitudes. And thirdly, disease-related knowledge base as a requirement to enhance behavioral changes. But what defines a transition program? Quite a critical and crucial question. Based on the recommendations, a transition program should include the following components. To increase the level of patient knowledge, a comprehensive educational curriculum and a health passport are recommended. To enhance the self-management attitudes of patients, counseling and guidance should be provided to them, with the aim to increase their sense of self-esteem, their identity, and development of autonomy. Finally, interventions or strategies focusing on the skill set of patients should learn them how to take part in shared decision-making, how to become how to self-management and therefore take responsibility for health and care. Several components are recommended by experts based on the recommendations that we find in literature. Quite central in a transition program is the indication of a transition coordinator. One person or a team of persons who are actually responsible for coordinating the transition program. for implementing this, but also evaluating and adapting this along the way. Besides this transition coordinator, there should also be an education program which also focuses on skills training. There should be an administrative support with links between the management at pediatric cardiology and the adult focused facilities, and the program should be evaluated. Furthermore, the implementation of a trailer transfer or transition plan should also become part of the transition program. And some centers could opt to organize specific transition clinics or joint clinics where outpatient assessments are performed jointly by pediatric cardiology and the ACHD care facility. Furthermore, there should also be some counseling provided to patients, especially for vocational choices. In case adolescents want to talk about family planning, the studies that they want to achieve or start, etc. There should also be some kind of evaluation or assessment of the readiness of the adolescent before reaching the transfer towards adult care. And of course, this all should be written down in a policy, a global policy which is implemented throughout the whole hospital, which could facilitate this transfer and transit.
Excuse me, are the slides blank or is it just my computer?
Programs. Well, providing transitional care should be considered as a complex intervention. And in order to deliver a successful transition service, it needs to be a service that can be developed and will evolve over time based on insights gained at a longitudinal perspective. So over the past years, several RCT-like studies have been implemented in practice, such as the Chapter program, the Transition with a Heart program, and the Stepstones project. But of course, these are just some examples of
It looks as though, are people not seeing the image right now? Is that correct?
Yes.
No images.
No images. Let me try to reshare, okay? Sorry about that.
That's why I said no images.
Yep. Well, of course, I can see it in my office just fine, but that's not going to help anything. So hold on one second. Yeah, for some reason it's been lost off my screen. I apologize for this. Give me just one more minute. Okay. Do you see that?
No.
No?
No. We see your...
We see desktop, we see the Google page, but not the slides.
That have focused on the effectiveness
Can you hear
of
that?
transition programs. Preliminary results...
Yes, we can hear, but we are seeing your browser.
Likelihood...
That's no good.
Wait a moment.
I apologize to everyone.
No problem.
Any better?
Yes.
You see the movie? Do you see the movie now?
We start the movie.
Yes.
of delay in adolescence
Yes.
Could also improve the level of disease-related knowledge and the self-management skills of patients.
Gil, there's something wrong with the video.
Yes.
I've lost audio again.
Yeah.
Okay, conclude.
You can't mute your microphone. If you mute your microphone, the sound disappears.
actually requires a quite comprehensive approach. This means that in order to develop, implement, and evaluate such programs, commitment of all program leaders and personnel is highly required. The transition program itself should focus on a multitude of aspects. It should focus not only on education and disease-related knowledge, but it should also include some interventions and strategies that focus on the development of self-management skills and also on some attitudes. Implementing a transition program might reduce the occurrence of care gaps and therefore might enable the achievement of a continuous care program along the lifespan of a patient. And it mainly aims to provide appropriate medical care and in the longer run optimize the quality of life of our patients throughout their entire lifespan. I would like to thank you for your attention, and in case there might be any questions, you find my contact details.
Again, I apologize for the technical issues. It's the first time I think we've done a video production. But hopefully the gist of that got to us. Thank you all, the 2,000 of you are here for probably one of the most important lectures of the webinar. And I'll turn this over to our friends from the Saudi Heart Association to introduce our last speaker.
So again, good afternoon, good evening. It's turning to 7 p.m. here in Saudi. So thank you for everyone staying here. It's my pleasure to introduce Dr. Al-Umrani. He's the president of the Adult Congenital Working Group. He's a pediatric cardiologist in training. He was trained in Mass General Hospital, affiliated with Harvard Medical School and Pediatric Cardiology Fellowship and Intervention. And he joined again the Adult Congenital Pulmonary Hypertension at Boston Children's Hospital and affiliated with Harvard Medical School. He had been working initially in King Faisal Specialist Hospital, then National Guard Hospital. He's, as I said, the president of our newly growing Adult Congenital Heart Disease Working Group, which is a part of 17 society and working group in Saudi Heart. It's also a reminder to everyone that you are welcome to our virtual Saudi Heart, which will be 8, 9, 10th of October, this coming October. So it's for you, Dr. Umrani.
Dr. Najashi, could you put the link to your upcoming excellent program in the chat box, please? And then everyone will.
Yeah, definitely, I will.
Thank you.
Do you guys see the slides?
Yes.
Yes, we do.
Thank you, Khalid. I would like also to appreciate the Saudi Heart Association for their tremendous work with Professor Al-Habib leading such collaborative work with the international community. It is also an interesting topic that I would like to shed after the, following the great teachers that I've worked with in the past, and I appreciate for giving me this chance. What I would like to go is talk about a journey which I called with almost 350 years disease. I don't have anything to disclose. With the initial description that was described in 1671, where the blue baby description for the turned out to be later on labeled as Tetralogy of Fallot, followed up by the series of 5 manuscripts, 5 patients with the 4 anatomical features, the RVOT obstruction, the VSD, and overriding of the aorta with RVH, which subsequently carried the name of that publication. Then with the introduction of the BT shunt for such patient in 1945, the urge of Tausing, Dr. Tausing, with the help of with the surgeon Blalock and Vivian Thomas, and getting these babies offered surgical intervention with the BT shunt, sort of like helped in their carrying their life further. And with the introduction in 1954, the first cardiopulmonary bypass and the first tetralogy repair, moving forward with the primary neonatal repair in the early 70s, and subsequently recognizing the late complication after a long journey with repair of these patients. The introduction, subsequently the introduction of the percutaneous valve and the hybrid procedure for such lesion in 2015. So going with this almost 300 years of the first description and the accurate diagnosis and effective treatment of this complex silent congenital disease have become the standard of our practice. With the turn of the century, approximately in 1997 when this first publication came, interestingly, around 25 years of the repair, there is this drop or attrition of their outcome, where most of the complication or the hemodynamic sequelae appear on these patients. Some of the challenges that these patients will face, whether they are medical or non-medical, I'm not going to talk a lot about the medical challenges. A lot of the talks you heard about it from the repair of the tetralogy that constitute the largest survivors from the adult congenital, the cyanotic repair, more than 85% survival. In the adult life, the residual hemodynamic sequelae are ambiguous despite the full repair. Morbidity and mortality rate increase with their time. Sudden cardiac death appears to be the leading cause of death, approximately 0.3%. Multiple factors also affect their cardiovascular impairment, whether the damage of the myocardium due to their long-standing palliative shunt or insufficient myocardial protection that was in the earlier years of repair, the sequelae from the surgical repair, whether the shunts, the volume overload, the scar. Subsequently, we heard some of the talk about earlier about the electrical conduction problems and the coronary arterial anomalies, whether they are acquired or congenital. The tremendous adaptive capacity of the RV cause a challenge with delayed symptoms and sign of over cardiovascular decompensation. Some of the biomarker blood work and neurohormonal analysis can help with the introduction of the cardiac MRI around the world, helped a lot in recognizing some of these medical challenges early on and offer them intervention accordingly. Other problems which are non-medical, which is the occupational related challenges, especially when we deal with the patient growing into adulthood, becoming more independent, recognized around the world, the adult with chronic illnesses, the employment rate nearly twice as high as the normal healthy individuals. The higher rates of employment are seen in more observational studies compared with the general population, especially with the patient with severe congenital heart disease. And usually physical problems are often reported as the reason for that. Fatigue, decreased concentrations, exertional dyspnea. I will shed some also of these unknown factors, the neurocognitive that get into play with these patients. And all of these will go into a vicious cycle of more fatigue and physical problems and recurrent sick leaves and absence from work. Some of the known work barriers that they can face: job content, the load of the work itself, the job condition, temperature, traffic, moving around, hours, long hours, or the flexibility of the job, inter-job relationship between colleagues, stressors, whether related to the stresses of the job itself or the surrounding or the environment they work with, and also the ability or the processing ability of these patients also in relation to the work that they do. Some of the work facilitating factors that can encounter or balance the previous slide: right amount of physical work if it is available, accessibility to the job with the commute, flexibility of hours, the condition, relationship with the co-workers, more of a job autonomy will ease the tension around them, in addition to the emotional support if it is available. The neurocognitive challenges, which is, I think, is becoming more and more understood nowadays. Some of the earlier factors that was thought is whether it was exposure to the cardiopulmonary bypass or circulatory arrest. Some of the factors like family socioeconomic status and parental education. We see it a lot, especially now we are an international community. The interaction is through the social media is very active and short. That will affect some of these patients. Some of the actions or activity that may give us some information is the comprehensive genetic testing that is coming around that may shed some lights on these neurocognitive hidden challenges that we see with these patients. In addition, as Professor Jonas mentioned in one of his publications, the cardiac neurodevelopmental outcome consortium, that also helps in shedding some of these association and some of the risk factors and try to link them out. Special conditions with these patients, in particular to women with post-tetralogy repair. We know the hemodynamic, this is the famous slide with the hemodynamic cardiovascular changes in pregnancy. We understand the plasma volume tremendously increase slowly and maximize over the third trimester. Stroke volume early on from the first trimester and plateau till end of pregnancy with the heart rate changes, the systemic vascular resistance drop with the placenta in the body, and subsequently the cardiac output. All of these changes in hemodynamic in pregnancy, you add it to the congenital heart disease patient that we are facing in general. During labor, the cardiac output increase, heart rate, blood pressure, venous return, and circulating blood, in addition to the postpartum, where the autotransfusion from placenta, and that will increase the preload and cardiac output, to keep that in mind. So in general, the pregnancy in postoperative tetralogy patients usually well tolerated. There is an excellent neonatal income, and the recurrence, though the recurrence of risk of congenital cardiac disease is high due to the transmission from a genetic point of view. Important in this particular type of this patient is the preconception. The clinical assessment that can include some blood testing, ECG, looking at the QRS duration, echocardiogram, cardiography, cardiopulmonary exercise testing, and cardiac MRI can help in, as a preconception when we see these patients, in addition to genetic testing, for example, assessing for DiGeorge syndrome. Such planning may bring forward to us as a physician a detailed heart assessment that will bring, if the need, an intervention prior to pregnancy to be addressed before that, and also will help in recognizing risk of miscarriage and prematurity and having a small gestational age baby, especially in unrepaired cyanotic patients. During pregnancy, each time trimester, ECG and echo, complicated patient may warrant especially with functional deterioration, may require closer follow-up. Some of them may need bed rest, oxygen supplemental therapy, in addition to anticoagulation, just to help with the maternal oxygen and prevent thromboembolic, especially with the cyanotic unrepaired patients. During labor, in these patients, as I stated before, they usually do well. The repaired one, vaginal delivery is usually recommended with epidural anesthesia. Assist delivery to be considered with aortic dilatation more than 5 centimeters, and in patient with symptomatic heart failure. Continuous ECG telemetry may be useful, particularly if there is a history of arrhythmia. Postpartum observation, usually for about 24 hours in this patient. We have to shed also look in particular for fetal complication that may affect the fetal growth and gestational age. With being small, gestational age can occur up to 35% of these patients. Use cardiac medication prior to pregnancy, predict that. The risk of vertical transmission for congenital heart disease is higher than the regular population, is about 2 to 3%. How to prepare for such a journey? Recognizing and having the care access. We do recognize the different health system within the country itself, or even within the city, that create different barriers. and having also to share or study the priorities for action for these patients. To help and focus on the lifelong care rather than just a transition, and having, as published recently, the new guidelines of adult congenital, and implement that within the community, strengthening the partnership between providers and patient organization. This is sort of like a small table roadmap looking at from the goal on the left side table here, where you look at the awareness, long-term engagement, the awareness of clinical issues, subsequently moving up to the ladder of involvement till going to the global health agenda. And on the left side is how these can be achieved from different tactics, the media, education, and having meetings and discussions. One particular important thing I think regarding to such patient is creating a research, as Dr. Al-Halees mentioned, about the registries. And just to shed some light, the collaborative work for this kind of lesion I think is a very essential. This is one of the new studies that are going to be conducted now currently in the US, enrolling about 3,000 tetralogies and having a 2 years follow-up of repair. Not much really of long-term, but it at least sheds some light of the collaborative work that can be achieved for such patients. Approach is another also registered and big study that has already concluded. It's an institutional cross-sectional study, assessment of pattern of patient reported outcome in adult with congenital heart disease. It involved 15 countries from 5 major regions. The main domain with looking at the perceived health status, the psychological functioning, the health behaviors, and the quality of life among these patients with tetralogy, post-tetralogy repair, and they are adult. Not only that, but also this, with that interesting in mind, with all of the information that happened with approach 1, now there is an approach 2 study that have many multi-international involvement, and luckily our centers also have registered and started involving with this patient. The aim of this to address the new research question was to explore the differences in patient-reported outcome measures and patient-reported exercise measures. In addition, exploring the healthcare needs and healthcare consumption of subgroup of older adults with congenital heart disease, with particular focus on the Flaherty phenotype. This is an overall for congenital heart disease, but I think such a collaborative work can help. From that study, for example, there was a biggie bag attachment to it is specifically for looking at the frequency miscarriages, preterm birth, and stillbirth, interrupted pregnancies in women with moderate to severe congenital heart disease. So there was a questionnaire addition to that, which an expansion of the same study, which trying to get information to shed some of the light of the challenges that we see on long-term care of these patients. So in summary, just want to make sure that we don't usually, when you say total correction, it's actually, I look at it as a missing word. We need to have the education and long-term care maintenance from childhood, appropriate routine follow-up, especially with institution at the institution level and up to the health officials. Transition to adult congenital heart disease specialist center with local and governmental regulations. Health coverage availability. In our community now, we are moving to more semi-privatization. That is also another challenge to face with these patients. We have, and especially like what we do now, the taking of the advantage of telemedicine and possibly portable testing technology that will help in getting these patients taken care of even remotely. In addition to the psychosocial support, whether community or patient group, society, and some of the enforcement of health regulation or new health regulation that will help. Thank you very much.
Thank you very much, Dr. Al-Mourani. I think that, and compliments, because we learn that this story started 350 years ago, and we are still consider Arthur Fallot the first original description. So, and as you say, this is a very long story, and now we are very lucky that people that has operate also 30 or 40 years ago, now they are able to join and have a child and build a family. And this is, for me, again, we are very young, we're still young with this job. And pediatric cardiac surgery, in my feeling, is a very young specialty. And as you know, the opportunity to have people so young that you operate and they can build a new family, and people like you that build a guide, follow the guidelines to bring them safely to the pregnancy, I think that is an amazing way. And again, I would like to ask from if there is some comment from the panelists, and everybody's tired. Pranava is okay. Is okay. Professor
Yes.
is okay. I think that you can make some summary about this special meeting.
I think this was excellent, and it's an honor to be a part of this, and I really enjoyed every talk. And there were some very, very nice and thoughtful questions. I hope that all the panelists, myself included, addressed those adequately.
Thanks, Dr. Al-Halees, because the presentation from you opened a new world for us, because sometimes we don't know what happens in a different center of the world, and the spirit of the academy was just like this. And your presentation was so clear. So I wrote to you, was very concrete, and this makes the sense of what we are doing. And of course, sorry.
I think the approaches in different parts of the world for different diseases is a learning experience. And I think, with such platforms that you are providing, I think the knowledge can be spread and we can learn from each other very well. And I think that's a great advantage of webinars like this or cooperations like this.
Thank you very much. Laura, thanks. Your imaging was unique. I can operate easily with your images.
Thank you, Sasha.
Thank you very much.
Thank you.
Can put easily a device, because MRI reconstruction and CT scan is.
Thank you.
Learn from Elizabeth that when you close with a patch or when you put a stent on RVOT, arrhythmia treatment is finished. So we have to think in this way. And Dr. Ziyad Professor Ziyad is laughing, but I'm sure this is make a big sense of message. We have this message also in Europe. We have the group from Holland. They are working a lot about this, and this message of Elizabeth, I think, was very important.
That's why, Sasha, we need biodegradable stents.
Yes, yes.
That would be lovely.
And
Yes.
Please.
we need less interventional also, people.
Thank you. Thank you, everybody.
Thank you for having us. It's been a pleasure. Thank you.
Thank you.
Thank you. Have a great night, everyone.
Bye-bye.
Thank you.
Thank you.
Good night.
Thanks a lot.
Happy
Bye,
Thursday.
everyone.
Happy Thursday. Happy weekend.
Yes, thank you
It's
very
our
much.
weekend.